Up here and sit in on your class.
Well, it's a whole different topic, that's for sure.
Yeah.
You're not gonna get that much design thinking here.
That's project management.
It's project management, that's good
Yeah.
stuff, right? But it's all pharmaceutical this year, so,
That's okay.
yeah, you can live with that, right?
Yeah.
Yeah, okay.
Good morning, Professor. How are you? I cannot hear you. Nope, still nothing. I can see you, but no voice.
I was gonna have you present first. Is that okay?
Yeah, that's fine. I can hear you now.
Okay, perfect. Yeah, Chinmay's not gonna present, so it'll be you and then Ed Vesh.
Good.
And then between the two of you, you've got 30 minutes, so maybe, 10 or 15 each should do it.
Okay.
You got some nice food here you're missing out on.
I know it. The classroom looked a lot bigger too.
That's ITW. It just looks different. It's tiered.
Nice.
I'm gonna put a little Santana on while we're waiting. Morning, how are you? There's all sorts of people in this building today, huh?
Yeah.
Professor, is that you playing the music right there?
Yeah, that was Santana.
I know.
Not bad, huh?
Not bad. Can I share my screen now?
Yeah, go ahead. You can share your screen. Let's give people a few more minutes to show up here. Everything seems to be working on the technology front. We got lots of food, not too many students. So Usman, is your new job public? Are we allowed to talk about it?
Oh, yeah, sure.
Okay, I'll make mention. Everyone's here. Great.
Amen.
Hey, how are you? Thank you. I guess people are trying to find which classroom we're in, right? Yeah. Everyone went upstairs.
Oh,
So all that food out there is for us guys. So don't think it's MPD food. It's our food. So we got some nice Panera. So some of it's warm, right? My quick question, Georgie, how are you?
Good, very good.
You hanging in there? You hanging in there?
I have a quick question. I saw your notification about the special presentations.
Yeah,
Can we make one more room?
maybe. Yeah, you got yours?
Yeah.
Yeah, I think so, because Chinmay just stepped away. So, yeah, why don't we do yours as third? Okay.
Yeah, the last one would
Yeah,
be
we're gonna
great.
try to do everything in like 10-minute slots. So,
I will try to catch.
okay, sounds good. Thank you.
Yeah.
Georgie, you cut down on my time now.
What's up?
You cut down on my time, man.
Really? Why?
I have to present in 10 minutes now.
We're giving him an excuse to go short.
Ah, got it. Okay, perfect.
What he was looking for anyway.
I can fit in 5 minutes as well. I did have a short one about you will see.
Okay, we'll take a look. So welcome everybody to our final presentations for 426. Before we get to the final reports from Team 6 through Team 1 in sequence, we're going to try to do them in 10-minute slots, 5 minutes for Q&A, okay? Special topics. Chinmay has already submitted his online. So I'll be posting and making those available to you, I think maybe through YouTube or something. I think that's probably our best way to share these things, right? Usman is going to go first today. Advesh is going to go second, and time permitting, Georgie is going to go third. So we'll each have 10 minutes for special topics. Keep it crisp. We keep moving. We do have some guests today. So Horizon Pharmaceuticals is going to be here. We have Olga and Zoe. Those are the folks that are doing the projects with us with Horizon. So I'm told that there's still one open slot. So if anyone's still interested in special projects with Horizon, I mean, I can't say for certain, but it's possible that it'll lead to an internship over the summer, right? But at least it's something paid this spring. So if you haven't thought about it, give it some thought. I think they're going to be impressed with what they see today. And, you know, frankly, it's fortuitous that they came to us with projects at the same time we were working on pharmaceutical R&D as part of this class. So I don't know if you believe in fate, there's a little bit of fate going on here. So maybe we can take advantage of that. Also, we are working with some other projects that might be coming down the pipe this spring. So keep your eyes open. Other than that, I guess, Usman, I'm going to give you your 10 minutes. So take it away.
Sounds good. Can you guys see my screen?
Yes. No
All right,
problem.
perfect. Good morning, everyone. I'm going to be presenting high velocity project management, and I will try to do in 10 minutes time frame. All right, so let's get started. My name is Usman Rafiq. I'm going to quickly take you over the introduction. What is high velocity project management? Then I will talk about a method that you can use to execute these type of projects. Then we'll talk about pros and cons, benefit, limitation, risk associated, and then the industries it's used in. I will conclude it with my personal example, how we use this kind of method in my project, team management, and then we'll conclude it. All right, so what is, and feel free to stop me if you have any questions. Let me know if you have any questions in the middle. So what is high velocity project management? You know, high velocity means more deliverables in less time. It's the measure of productivity rate of the project with respect to the produced, validated, deliverables.
Our chair is Tom Zero.
All right. Here, if you like, or anywhere you want to here.
So, okay. It sounds really simple, but it's not as simple because you have to create more deliverables in less time, and then you have to validate and get accepted and present it to the customer. And then you need a specific method to execute these kind of projects. So what is a method that we can use to create more deliverables in less time? One of them, method to that madness, and you've heard a lot about this in the past few months, I'm pretty sure, but I'll quickly go over it as agile. An iterative approach to project management. It delivers value to the customer on a weekly or bi-weekly basis. So fairly quickly, you can get some kind of value to the customer. Weekly sprints let you evaluate the velocity of that project, and we'll deep dive into it, how you calculate the velocity of that project. And usually you work in a small team of 3 to 9 people, which makes it manageable. So when you're moving at a high speed and you're delivering more in that speed, you want to keep that team small to make them manageable. And to get the deliverables out faster. Right?
By the way, that's a little bit counterintuitive, isn't it?
Yes.
I mean, don't we normally throw people at problems? If we have a problem project, don't we want a bigger team?
We do, but then managing those people, like it's going to be really tough for you to make accountability and get deliverables out of those people. More people in there means more questions, more confusions, more opinions, and you want to avoid those. You want to define what the plan is, and then you want to move on to execute that plan because you want to move at a pace and you want to get the deliverables out as fast as possible. So if you want to have a mature model where you want to move at a slower pace, sure, throw more people in there. But as soon as you have more people involved in a project, obviously your time frame is going to go up. So you won't be moving at a pace you want to move.
Okay.
Depends on you. So a valid point, by the way. So Agile, it works in a sprint phases. You design, you develop, you test, deploy, review, and then you launch it to the customer. But how is this possible? Where does the planning come from? The planning actually comes from this mainframe. So you could have some kind of input from a customer, team, manager, executive, whoever your KPI is going to define the priority in your backlog. And those priorities backlog then are communicated to your team. And I'm pretty sure you guys really well understand this because you guys have heard about this over the past few months a lot. And that goes back into the backlog. And from there, the team decides, okay, we have this kind of skill set. We're going to execute this. This is the most wanted task for the customer that can make the most value for the customer. And then they go on that sprint to execute that task. The sprints go on for 1 to 4 weeks, depending on the complication or what resource or skill set you have in a team. And they will execute that and create some kind of value to the customer. Within those sprint, you have a technical lead, or you can call it a scrum master, who keeps an eye on the team, does the daily stand-ups for 5 minutes to see how the team is performing, what are the burn down and burn up chart rate is within the team. And then he communicates that back to the project manager to see, if we need more resources, if we are executing what we need to get done in those sprints. And then by the end of that sprint, you have some kind of finished work. And then you decide, and then you do a sprint review to find out what was done through the sprint, what was not done, and that what was not done in that sprint goes back into your product backlog. And then you have a retrospective too, which is a peer review, which we will do by the end of this class too, to create some kind of accountability in between teams. But where does the velocity come into this? How do you calculate the velocity in these kind of projects or when you're moving at the space? So the velocity actually comes back from the product backlog. You assign some kind of numbers or points to what's in your backlog based on the effort that is required to complete that task. So higher the effort required to complete a task, you'll put the higher number on it, and so on and so forth. Lower effort required for a task, you'll put a lower number on it. So for instance, I'm a project manager. I want to move at a pace of velocity of 26. And I will tell my team, this is the pace I want to keep up. Based off that, the team will pick up some kind of task from the backlog that are 8, 5, 5, 3, 5, and that will calculate the velocity for that sprint. Now, that's the start of the sprint. That's the start velocity that has been defined by your project manager, how he wants to move with the project. But obviously, it's not going to be executed fully by the end of that sprint. And that's what tells you that if you need to assign more resources, you need to assign higher skilled people to that project. And that will give you some kind of feedback from it too. So obviously at the end of the sprint, you can see the velocity was 18 points. You covered some kind of points from it. The velocity you expected was not executed through that sprint. And then what was not covered in through that, you goes back into your product backlog. Then you talk to the key people, and then they tell you what needs to be prioritized into your backlog again, and so on and so forth. You move on, and then you define, okay, we want to meet, why did we not meet that velocity? And then whatever that feedback is, based off that, you assign more skill or you assign more resources to your team. So that's how you define a velocity in your project. So let's talk about some of the pros and cons of moving at such a velocity. So we can differentiate pros and cons into two different segments. One is product side, and then the other one is on the people side. So on the product side, you're covering more points So that means you get a faster deliverable. You can get early to the market. You have some kind of time saving because you're moving at a high speed. On the con side, you will get low quality because you're moving at the high speed, and we'll talk a little bit more about it. Obviously, it's going to cost you a lot because you have high skilled people working on this. There's low knowledge transfer because people are focused more on delivering than transferring knowledge. And then mostly there's a cutoff on verification and straight to validation because you want to save time. You don't want to spend time on verifying, and then you go straight to validation. In the feature side of things, for the customer, you probably get the high features because you're moving at high pace, most likely more bugs because you're skipping the verification part and going straight to validation. Fast ROI because you're moving at a faster pace, you're getting to the market first, so you can get a return on your investment faster. On the people side, you have a risk of burnout in people. You're moving at a pace, that people are working overtime. They're getting more done in less time. So obviously there will be a burnout in people, and these are high skilled people. So, that's a high risk right there. And then there's a low knowledge transfer because people are moving fast. It's a single system. Nobody want to come close to it. It's a standalone project. Most of these projects are standalone projects. And then there's limitations on it. It requires high scale because you're delivering more in less time, and it's not really cost effective. So make sure before you handle these kind of projects, make sure you have a high skilled people in your team. You can execute these kind of projects. If not, try to stay away. They're not really cost effective. There's a burnout in these projects, which is not really healthy in the long term. All right, so we'll put this on a graph to see how things work. If the product features on the x-axis, and then you have velocity on the y-axis, and weak, medium, strong on x-axis. As the product features are weak, low velocity, you have low burnout. As the velocity increases, weak features, you can probably get a high product quality. And as the features increase on the x-axis, and then you have low velocity, then you will get high product quality. But as the features increase and the velocity increase, then you have burnout on people and probably low product quality. Some of the industries these kind of projects are done in, mostly in software development kind of industries. You'll see it in Google, Amazon, Tesla, but it's gradually making its way into manufacturing and hardware development because people want to move faster pace to keep up with the customer, and they want to deliver more in less time. So the hardware and manufacturing is picking up the pace too with the software development. So I'm going to quickly give you guys an example of how we did it, of my own personal example, and I'm going to give you an organizational chart. We did it for the SpaceX integration tower, as you can see on the left-hand side. The integration tower is done, by the way. Check it out on Google if you guys want to take a look at it. It's a piece of art. It's called Macazilla, if you guys want to Google it. So I'm going to give you an organizational chart, and then I will tell you the importance of this organizational chart too. So I was on the design team. I had a tech lead and 8 technicians. I had an electrical lead who was making sure all the are there, they're verified, they're wipe tested, they're heat tested and ready to be used in our design. And then I had an operational lead who was making sure everything was operating smoothly, and a mechanical guy who was making sure that that giant tower was being built on time. So the importance of this is it's going to save you a lot of time. These guys are moving at higher pace. They're going to have a lot of questions. So it's really important to identify the key people in there, who to go to, who to ask these questions from. And you guys have seen this. We have covered a whole chapter in class about this. It's really important to define your organizational chart. So there's not a lot of who do I go ask this question and who do I go ask that question? You saw this in Pilt's example too. He did this in Motorola too. He created an organizational chart for people if they have questions, direct question, they can go ask. And if in case my technician had a question, he can go ask the tech lead, and the tech lead can direct that to me, and whoever the electrical lead is, he can go ask that electrical lead. So it's very well defined who to ask these questions to when we're moving at this pace. So there's not a lot of it. Make sense?
Sense. Can you quickly here, Usman? We're kind of running out of time.
What is it?
Can you wrap it up quickly? We're running out of time.
Yeah. I'm almost done.
Okay.
The product roadmap is planned to design, develop, deploy, review, launch is pixelated, but it looks very simple to, if you put agile on it, you can see that you can get this done. So how I did it, you get the input from the team leads, you put that in the product backlog, you decide that, okay, the mechanical guy is done, the electrical guy has tested all the parts and what we need to be done. For instance, I knew that I needed to develop communication panels and design and RDDs, inputs and output panels. And so I put a priority of communication panels in the product backlog on top. I assigned, because I knew that there's a lot of effort that requires to build those panels. So I will put a higher number on those panels or a number stamp on those panels. And based on that, the team will come in and pick up those panels from the backlog and start to build on those. So I put the low skilled people when we were doing the build, and the technician lead acted as a scrum master. He talked to these technicians on a daily basis, get what they're doing, how they're progressing. And then when we were deploying, the tech lead was actually deploying, because that requires a really high skill set for testing to be done. So this is how you can take that kind of method and employ in your projects and execute a high velocity project. And based on that, you can calculate the velocity too. I can know like how these teams are moving, how they're performing, and what they're getting delivered. And if they're not delivering that, then we'll have a stand-up meeting at every Monday morning to see what was delivered and what was not delivered. All right, so I'll try to wrap it up, take your questions if you guys have any questions.
Okay, thank you, Usman. Nice job. Are there any questions for Usman? I know we've been looking forward to this pretty much all quarter long. We're wanting to hear how SpaceX does things, and I think you got a good flavor. What I saw here was almost an encapsulation of the entire quarter in just a few slides in terms of like how they do agile processing and how they do their sprints. Really, it's multiple chapters from the book squeezed into about 7 days. So, questions for Usman? I think you stumped them. They have no questions. I guess your slides were totally comprehensive, Usman. Nice job.
Thank you.
Thank you. So everyone knows that Usman's moving on to Marshall Space Flight Center over at NASA. Is that correct?
Correct.
Correct. Congratulations on that. Well done.
Thank you.
A round of applause. I don't remember too many MEM students going to NASA, but I guess, congratulations. That's fantastic. Next up, we have Advesh. I guess, Advesh, you can share your screen. You can do it from here. You don't have to move back. You can do it from here. Is it on your laptop?
Yeah, it's on the laptop.
Okay. Are you?
I just want to.
That goes for everybody who's going to be sharing their screen today or presenting. Make sure you have your Zoom connection going. While we're doing that, let's welcome our guests. We have some guests from Horizon Pharmaceutical here, right? So in the back, we have Zoe. I believe Zoe's back there. Thank you for coming. Olga back there? No?
We didn't make it this morning.
Okay. You have another guest, though. You want to introduce him?
Yes. I'm Zoe Hefner. I lead international business operations at Horizon Therapeutics. I'm looking forward to your presentation. And then I brought my colleague Tom, who I'll let him introduce himself.
My name is Tom. Worked in the pharmaceutical industry for 25 years, primarily outside the U.S., building compliance programs to manage varying regulations from market to market. So excited to be here.
Okay, thanks Tom, and thanks Zoe for coming. We also have Andrea Franks. Andrea formerly from Pfizer?
No, still with Pfizer.
Still at Pfizer, there you go. I don't know, if you want to introduce yourself, go ahead.
Yeah, I spoke with some of you guys earlier a couple weeks ago. Andrea Franks, I work for Pfizer in the contract manufacturing for Pfizer Center 1. I've been doing project management in pharmaceuticals for over 25 years, so I'm really excited.
Okay, thank you.
Checkoffs, we've got comm-offs,
Yeah.
and compliance.
We've got a complete project team here. We can actually, we can take a pharmaceutical to market here, right? We can take
And I'm a
it.
graduate of the material science department here at Northwestern.
Oh, wow, so this building should be very familiar to you, right?
Yeah.
The tech building in particular.
Yes, but I worked down in the basement of tech for a long time.
Yeah, I'm sorry to hear that.
Graduate students, right?
Well, I'm sure things have worked their way up since then. So, okay, thanks for coming. Advesh, you have 10 minutes, take it away.
Good morning, everyone, and welcome all the guests. So I'm going to talk about project management knowledge area, the PMI approach. So
You can take off your mask if you like, if you're comfortable.
So talking about process groups, in PMI, they have divided it into 5 groups. That is initiating the project, planning, executing, controlling, and closing. And in these process groups, they have divided it into knowledge areas. That is integration, scope, time, cost, quality, resource, communication, risk, and procurement. So I'll start with integration management. Integration management is nothing but all the projects, all the process knowledge areas linked together, and it is one of the main things which helps us manage all the other process areas. So it tells us whether our project is aligning with the process goals, the goals of organization or not, and then creating a plan how you will achieve a goal. Going on to scope management. Scopes are generally, you might have seen in companies, like if you are doing a project, you usually face this thing that there are 10 more things added to the project at n number of times. Now it is being managed with Agile, but for PMI, it was more of scope management, initiating what was there in the scope and planning it prior to the project initiation and project execution. So it was mainly to avoid gold plating and avoid scope creep. Coming to communications management. So does anyone know the difference about communication and communications? Anyone of you? So communication, okay, go on. Sure. No. Yeah, that is a great difference. So communication is while you communicate with someone, it is called communication. But communications is the channel which is used to communicate with others. So here, communications management means how you are managing the channels which are used for communication. And communication with whom? The stakeholders. So this is going to coincide with the stakeholder management a little bit, but I would like to make sure that you know the difference. This is the path which we are using to communicate. So over here we have to maintain the transparency, remain unbiased, prioritize punctuality, 3C communication, clear, concise, and consistent. Then stakeholder management. I put it just after this so that there's no confusion. Stakeholder management is how you are managing all the members involved in project. Not only your customers, because customer is not the only stakeholder you have. So those who are involved in the project are stakeholders, and we have to make sure that everyone should get the information they need to know. No one gets more, no one gets less. You might have seen people going on to the super boss and telling every story, and super boss might be like, I don't want to know that. I want results, I want objectives, that's it. So this is what we have to manage, how to communicate and whom to communicate what. So this is basically the RESIC matrix we already gone through in the class. Then resource management. We usually see the major bottleneck is resources, whether it's a human resource or cost or anything. So everything comes in resource, and basically here we are talking about mainly the human resources and how to manage resources when there is a constraint for resources. So basically input is the project charter, and we have to manage how we are going to distribute resources over our projects. Then coming to risk response mechanism, all the projects have this a risk associated with them. We also found out risk adjusted NPV. So it's mainly the thing that project might fail. So what you're going to do? So here project manager PMI has its set guidelines, tools and techniques, and what we are going to get is risk management plan. And then schedule management. Schedule management is nothing but making a plan before you go ahead with execution. So you have everything, you have your resources aligned, you have your risk plan there. But if you do not have a schedule, you'll fail. You are definitely planning to fail. So if you do not have a plan, you are planning to fail. That's why there's a schedule management. And then coming to cost management. Cost management is something which is priority for all for-profit and also for non-profit organizations also. If you're running an organization, you have to make sure that all the costs in project are managed and you're not overshooting the costs. So basically, these are the inputs, tools and techniques and outputs. We have to make sure we avoid surprises in costs. We calculate all the input costs, all the possible costs, take a factor of safety for that also, and consider all the costs properly. Then quality management. Quality is something which depends from organization to organization. Some might be valuing quality as a first go parameter, but some might be taking some other parameters as the top priority. But I would say PMI considers quality as one of the top criteria to monitor the success of project and the scope, you say. So there are 4 types of cost of quality, that is prevention, appraisal, internal failure, and external failure. The most costly one being, which one is the most costly one? Can anyone go for it? Which one is most costly? Cost of failure.
External failure.
Yeah, exactly. So if you are going for an external failure, it's on the customer end and you are losing your reputation and your cost also. So coming to procurement management, we know that we can't, with limited resources, sometimes it happens that we are not able to focus and we are not able to focus on all the aspects of project. So we have to make sure that we outsource some of the work. So here is procurement management, where it provides a idea about how to outsource and helps in coordinating beforehand. So if you are planning for an outsourcing, procurement management will help you to make sure that you're making all the legal formalities and making sure the vendor is online and everything is aligned with the project. So this is procurement management. And then I added this thing. This was not in the knowledge areas. So this is feedback and knowledge retention. This is involved in some of the process areas as an output parameter, but we have to make sure when we are passing it to the next project, when we are closing the project, what we have to do, we have to take feedbacks, identify comments and recommendations, document and share findings, analyze and organize for application of results. So we have to make sure that we are applying our results in the next process, next project, and then store it in a repository, because you should make sure that you are going to retrieve it and you can retrieve it easily. So it is basically that, and I guess I'm done. Thank you, and if you have any questions.
All right, thank you. Any questions for Ed Besh? So you talk about knowledge management. I think that's actually part of the project closure, right?
Yeah.
Project closure. So back there.
I was gonna say that was great, and having done project management for so many years, one of the things when it comes to procurement, we're finding out a lot of times now, and we can talk about this later, but supply chain is a huge issue, right? It's becoming a bigger and bigger issue, especially with the pandemic. So that's something that, you know, you want to work closely with procurement, and also if you have a component where you're single sourced, that's another thing you want to work with procurement to maybe find a second source for a critical component. So those are two really good ideas, but great presentation. Thank you.
Sourcing and supply chain are becoming major. I mean, in my day, it was something that was managed. Now I'm starting to feel like it's almost unmanageable, right? It's becoming this kind of unknown where you're not even sure whether the commitment you received in writing in a hard contract can be fulfilled.
We just experienced that. We placed an order for stockers for a product in December. They gave us the delivery date of August of this year, which is really hugely long. Usually it's 60 days. They came back last week and said, oh, we're gonna have to extend it to September of 2023.
Wow. Oh, wow, that's crazy.
And the product that stopped.
Yeah.
So
Thank you, Andrea. I believe we have another new guest. Are you Olga?
Yes, hello, nice to meet you. I'm from Horizon Therapeutics.
Okay, thank you, Olga. Thanks for coming. Your colleagues are right behind you. Andrea Franks is from Pfizer. She's right behind you as well. So we're going to be doing pharmaceutical presentations in about 5 minutes. We're going to give one last presentation on special topics to Georgie. So Georgie, if you want to come up. And for the benefit of our guests, we've chosen 6 therapeutics from the Pfizer pipeline for today. And each team is asked to do a comprehensive project plan, which includes a risk-adjusted net present value calculation. So they're not looking at just the costs or the time frame to get to market. They're also looking at the market response. In other words, what's the revenue potential over 3 to 5 years? So they're literally looking over the entirety of the patent duration until effectively the patent expires in the product. So you're going to see 6 examples from Pfizer starting in about 5 or 10 minutes. But until then, Georgie, take it away.
Take care.
Good.
Hi, everybody. I know we're running short of time, so I will try to keep it really short. I wanted to discuss this topic. It's not really super related to project management, but it's related about management team inside of your company and outside of your company, which makes a lot of sense, especially when you operate in the field of software or IoT. So today we're going to discuss this small, really nice device. So let's imagine we are a startup, young startup out of Northwestern University, and we decided to build this great, amazing device, which has one purpose: to track the number of people that are coming to commercial space, let's say Louis Vuitton shop or commercial malls, because we want to provide the companies number of people that are coming there, how many times to repeat, etc., etc. So all analytics about their own customers, which by the way is very, very actual during some COVID, because there are some restrictions, people density, etc., etc. So we decided to build this device. What do we need to do it? What we need, where from we need to start? Which are the main components of this project? Any ideas? I can say one. One is hardware. We definitely need to do hardware part. Something else? What do we need?
Infrastructure.
Infrastructure. Interesting. What do you mean?
How are you going to make sure that that signal gets captured somewhere? It's obviously sending some sort of signal, right?
It's Wi-Fi.
Okay, so you have Wi-Fi infrastructure.
Yeah, we had a really nice presentation about Aruba infrastructure, by the way. So we can connect it to Aruba right there.
Okay.
But let's talk about the device itself. So because we're running out of time, we need to build AGI, which will work inside of the device and will track using the cameras people in the room. They'll figure out how many people there are, if there are our employees, etc., etc. And as well as we need to build a test platform. The platform is something that we will provide to our customers. They will have a web page to single sign on and see the data. We can't send them report in Excel, right? So we need to provide some meaningful way to gather the data. What is important here is that Edge AI, it's a part of this device and hardware as well, which is core of our project. It's super important to control it. It's super important to keep that knowledge inside of our company. But I can't say the same about that platform because it's like, in this case, it's relatively easy stuff and we kind of can give away control over it. So now we can discuss how we can get the parts of software and hardware done. So the first one, most obvious one is in-house, right? When we find some other students in university, invite them and starting building it, there might be a PM, might even not be a PM, might be product manager, and like all together we're building, starting doing something. Which you think this is good fit, software, hardware, or web platform to do it in-house? Ideas? Okay.
Or software.
AI.
Yes.
Yeah, exactly. Why? Why software AI? Because it's our core, right? Because our own technology, the whole technology is inside of software, inside of AI. So we need to keep the knowledge in-house. So the second option is just think about outsourcing. When we become a customer to somebody else, and now we have a PM which works on the side of our vendor, and they have a team. We might have one more PM which works on our side who manages their PM. So we create kind of overhead, but what we get in this structure, so we don't think about how to hire the people. We don't care about what to do with the people when they will finish the part of their job. We don't care about management. We don't care about payroll, all that stuff. But what we get, slightly higher prices, and usually software does the stuff, but we will not have expertise. So as you can imagine, outsourcing is really good in case when you need something to be done faster and you don't much care about having expertise in that field. In case of our device, this is perfect fit for web platform because it's just a platform, right? It's just a way to show data. And the last means I wanted to talk, it's about stuff. What it gives us, it's a relatively new one when IT companies, software companies start realizing that outsourcing generates a lot of overhead, double layer of project managers, and there is no direct access to developers. You technically speaking, when you do outsourcing, you don't even know who are the people who are creating your software. And of course, you can't be very happy with it, especially in cases when you care about the software. It's your core main product. But when the outstaffing, it can be helpful. When you already have core technology inside of your company, but you need some extra resources, usually it might be an offshore outsourcing to decrease outstaffing, to decrease costs. But anyway, how it works. We have our own team inside of our company. We have our own expertise, but we need more hands, we need more people, we need more team. That's why we hire another company, which gets team dedicated to us. They don't do nothing else. They feel, they believe they work with us, not with their own foreign company. That company is kind of intermediate layer. They just handle their payroll, hiring, salary, wellness, all that stuff. This is a really nice model, and it's, I would say, one of my favorite ones because it balances cost. It gives a perfect management of team, direct access to them, and as well as it gives you feeling to your team that you kind of work all together. And in this case, it's very often when people from extended teams, they come to your own team and they kind of interact together. So to make it feeling like the same company. I think that's all I wanted to present today. It's 3 types of building software and hardware products on this nice sample. So thank you. If questions.
Thank you. Sorry.
Sorry?
Are you really dealing with
No, I just sampled to explain.
Yeah, I thought it was like we're really bad.
Not me.
So you were great. That's good. So I'm glad we've been able to at least cover some outsourcing. We didn't cover too much of it in class. Frankly, it's something that almost can be an entire class unto itself, is how do you manage and outsource, right? Which gets into contract management. I tried to incorporate some examples that were outsourced, including maybe even some case studies, but I was glad to see it here today as a topic. So
we had some conversations after classes, so that's why I picked this topic.
No, I'm certainly open to even having seminars, workshops, or entire course set aside for outsourcing, because outsourcing has become so prevalent in our industry, in many industries, a lot of industries, including pharmaceuticals. So contract manufacturing, contract research, right, Andrea?
I was gonna say, your last model is exactly what I do. I don't work on Pfizer products. I work on third-party manufacturing, third-party pharmaceutical products. Pfizer pays me, but I don't work on their products.
Yeah, it's kind of stuff, extended the team
Exactly.
with the pharmaceutical.
We
Yeah.
work very closely with our clients. So we have, my big team meetings have my team, the Pfizer team, which they're dedicated to Pfizer Center One, and then the client's team. So yeah, exactly, perfect model.
Yeah, thanks. Sounds great.
And when you come to our industry night on Thursday night next week, we're gonna have a talk about 3PL, which is third-party logistics. So effectively outsourcing the logistics. So you're gonna get various different discussions on that, including Uber Freight and people from the transportation center. But that's one of the hottest topics in logistics right now. So any other questions for Georgie? Otherwise, thank you very much. Nice job. If our guests want to move closer to the screen, that's fine with us. We got plenty of space in the rows here.
Good point.
Otherwise, team 6, we're ready to go with you. As I recall, team 6 is working.
No break? No break?
No break. We've only been here for 40 minutes. That's nothing.
Okay, so I can stand here.
You can stand right there. You're team 6, right? Perfect. So you're already there. You're already sharing your screen. Team 6 is working on a cancer treatment. We'll hear about it very shortly. So
these are current pipeline assets.
So we're trying to take the textbook and make it as real as possible. So
I can tell you what it is to be the outsourced person.
Yes.
But just much cheaper.
we should start, right? Let me say a few words here before we start. For the benefit of our guests, our students are not pharmaceutical experts, so they don't know the industry any more than what they could have learned in the last 10 weeks, and mostly through reading websites, reading the FDA.gov site. The point of this exercise is for them to apply estimation and scheduling methodology, as well as valuation methodology, to assess the value of a project that is in midstream. So you're going to see various therapeutics today and in various stages of development. And we're going to ask for a recommendation at the end as a go or no go. Does this project make sense from a financial as well as kind of an efficacy and every other aspect, or does it not make sense? And we're going to ask them to look at the portfolio as well. So at the very end, we're going to try to assess do all these 6 projects make sense in the context of Pfizer's portfolio today. All right, so take it away, team 6.
All right, we're team 6. And the drug that today we're going to introduce is a solid tumor treatment drug, which is using SHP2 inhibitor. This is our team member. We have 4 members in our team. So about the drug, it's part of the oncology category, and it's a small molecule. It's currently on the phase 1 development of Pfizer company, and it's using SHP2 inhibitor to treat cancer caused by solid tumors. Now it's submitted to FDA as the new molecular entity. So about the target disease, it's targeted to the solid tumor, and as we know that in most of cases, all cancers, solid tumor takes 90% of the share in the all cancer. Also, in the children, it's 40%. The most critical or typical solid tumor in children are the brain tumor, and also it can happen everywhere of human body. As we can see, it could happen on lung or anywhere, kidney. The target market. So the market is increasing steadily and very quickly, so we can expect it's increased 15% every year. And also the cancer rate is also further increased by 50%. So as we know, there were 15 million new cases by 2020 since 2016, and also 1.7 million estimated new cancer cases, and 0.6 million deaths in 2016 across the world. That means around 1/3 of people who got this kind of solid tumor that died.
So when it comes to reimbursement and insurance, there's always a question whether your insurance provider will cover the cost or not. So according to the Affordable Healthcare Act, which mandates every insurance company to cover the costs of your cancer treatment or any therapy that you are undergoing. And there's also a cap of how much you have to pay out of your pocket. As an individual, you are like there's a cap of $8,150. And if you are taking a family insurance, then there is $16,300 per year that you need to pay out of your pocket. And these are some of the examples of the insurance providers that are best in the industry right now. So we have done some comparative analysis, and these are the drug banks that are actually in the current market, and they have like huge market share. So as you can see, the key to that has the 8.98% market share right now because of the lowest cost, and it was launched back in 2015. Right. So this has the highest market share right now, and the revenue, as you can see, in 2020 was $14 billion. It's not less. So that is the comparative analysis that we have done. And on the basis of this competitors, we have done the pricing analysis, and
Yeah, sorry, it's me. Just a second.
Yeah, there you go.
so monthly price is like 12,500, 32,800, 17,000. So average is around $15,000 per month. And so we calculated the 2028 prices, and we adjusted it by 3.5% inflation rate, and we got these numbers. Now, we thought how our drug would actually compete with them in the price range, and we decided that it would be around $2,200 to $4,300,000. So, and that is the patent. So these three different patents, which are actually in the similar domain of SH2 inhibitor. The first one is in Japan. The publication date is actually 26
August.
26 August, and the expiration date is again 25th August in 41 because of the 20 years of patent that comes, right? So first one in Japan, second one in US, and third one in China. Project cost. Yeah.
Or how much more? This whole thing's gonna be numbers this morning, right? I mean,
Yeah, it's gonna be a lot of
I'm gonna
numbers.
get used to it.
Right. So now we need to figure out our project cost, right? As we mentioned, our drug is on stage number 1. And in this table, we just use 3 different resources to evaluate approximate amount of money that we need to invest to move to the next stages. And I believe these numbers are more or less accurate. I know like our experts can probably have access to more accurate numbers, but all of us try to do our best based on the data that we have in public access. One important, next one. Based on this data, we built a cost baseline, which actually shows us interesting things that in average, an expected way, our project will cost us about 400 million. But in a maximum case, it can go up to 1.2 billion to develop such a track. So we need to expect that cost could go even up to twice more than we kind of expect. Based on the cost schedule and cost and timing, we created the schedule as during the last presentation, we figured out that the best way to present schedule is exactly this way. I know it's really hard to read, but what we have here is the phase one that we are already in, and after we move to the phase number 2, to the phase number 3, to FDA approval, now we will have a go-to-market, which will not be here. So one important thing I would love to emphasize is that we will finish approval stage approximately in 2028, which is in 8 years, which is an average after 8 years from now. And we started doing 2 years ago. So now let's talk about risks. Pharmaceutical industry showed us that there are a lot of risks, tons of risks on every stage, starting from clinical and preclinical, in the middle we have FDA approval risks, and after we have the most crucial one, market risks. So let's take a look to clinical risks. Based on our research, I figured out that for cancer drugs, the approximate percentage of approval from phase 1 to approval is about 3%. We get it from these numbers, and yeah, and for on the next slide, I will present you market risks. So in our market, we have a ton of risks. We did really deep research in our report, but I think we can't fit all of them into this presentation together with mitigation plan. But there is one I would love to talk a couple of minutes about it. It's a market shrinking from treatment to prevention. Like it's a cancer drug, right? But who guarantees us that tomorrow we will not invite some things that will prevent people from cancer? Let's say genetic testing before even burning, or we will figure out some preventive drugs. Probably not vaccine, but anyway. Good news for Pfizer and bad for us is that probably our generation won't be able to use the preventive methodology. So we will, Pfizer and our drug will still have enough time to get back investment. Revenue. So we have 3 scenarios, how market will penetrate our drug, optimistic, conservative, pessimistic. It's a cumulative revenue for 15 years of being on the market. We have this plateau after year number 12. It comes from the date of expiration of our patent. We didn't find much data how it really will look like. It might go slightly up or it might go even slightly down, but we just wanted to emphasize when our patent expires, another companies can enter to the market with the same drug, but they didn't spend $1 billion 15 years ago to build the same. So, but we still like hope that it will at least will not fall down. By the way, these numbers are not present or in future. So when we move it to the today, it will be divided almost by 3.
Are these cumulative numbers?
For 15 years, of course.
Cumulative. Okay.
Yes, numbers.
So we'll never go down, right?
So you're literally gonna get about maximum $30 billion in optimistic case. So as we saw, our competitors already are doing 14.
Right.
So it's like quite good numbers.
These are not annual revenues per se. These are cumulative revenues.
These are cumulative, 245. But this graph shows annual.
Peak revenue of 31 billion.
Okay.
So
So it peaks at 31 billion annual revenue.
Yeah, peak is 31 billion, yeah, annual.
Can I start asking you a question?
Sure.
What's your indication?
Engineer, applied math.
No, indication for the drug. I mean, you had to have an indication to then decide what your pricing is gonna be, right? You likely won't get a label for all solid tumors. So you're gonna end up you'll have to make a trade-off, right, between adults versus peds, both. Are you just gonna go for, I don't know, like lung or breast or whatever, right? And that's gonna, man, if you could hit that whole target market, I don't know any pharma company that's done one drug at 245 billion. I mean, they're doing a lot, but.
What makes oncology therapies very difficult to forecast too is the off-label use of oncology therapies. very different than other therapeutic areas as well, too. That's why you see probably the large and the wide margin in the forecast between optimistic and pessimistic.
And I think it also will impact your timeline. So I might ask some questions, maybe you guys can just think about, like 8 years, what are some options you could take to accelerate that?
You mean,
Shorten the
clinical phase?
timeline,
Shortening the development.
commercialization
In
timeline.
parallel, as Pfizer
Right.
did during,
Right.
for COVID vaccine.
Right, using Agile or.
They can do it at the same time, like finish one and do 2 and 3 at the same time, in parallel.
Also,
Do you-
sorry, go ahead.
No, you go ahead.
Yeah, typically, when a drug goes generic, the revenue drops about 50%.
I just straight down.
Yeah.
Especially a small molecule, it's not a biologic,
Exactly.
50%?
straight down.
50%, yep.
Besides, we don't know about it. Now we know it.
Yeah, you're just trying to get as much as you can.
Yeah.
And why is your time to peak so long? Your time to peak really long.
That's a good question, by the way.
That's why I asked if this was a cumulative graph. Because otherwise, why would you take what looks like 10 more years?
So we start
Almost
with-
10 years to peak, right?
It's long because of this. We have an answer for the question, by the way. We just had a previous about pricing.
Some of these are biologics, not small molecules, right?
Yeah, some of the.
Features.
Yeah.
Yeah.
It's about market increase.
No, we didn't. We removed it from the slide. So in this competitive analysis, we have revenue in millions. So this drug has 14 billion revenue, let's say. And if I'm not wrong, they're on market some 4 years or something like that.
Yeah, but what did they do in year one? Like, what was their growth year over year, right? It's a struggle. You can look at their 10K. And see, oh, sorry.
I don't think that in 10K, pharma companies put the revenue for a particular drug.
Depends on how, well, each company does it differently, but they likely have that portfolio in their franchise or BU.
Uh-huh.
And they'll say oncology sales totaled, blah, 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 blah. You go look at their investor presentation and they'll tell you how much was due to.
But
each.
it's not just, it's a one drug, it's not an all oncology sales, right?
It depends, again, by company. But anyway, I mean, these are the ways you can refine the presentation, but I think as a learning exercise, the question, again, like what are some ways, the agile way to like run side by side, 2, 3, like what would be some of the things you think that would impact your ability to do that or not do that? Like where's the milestones that you have to hit to be able to know if you can do an expedited trial?
Probably the second clinical trial. Maybe after the first one, you can do second and third at the same time because the longest one is the third. Sorry, but the longest one is the third one, right?
Right.
So we can, if we pass the first one, we can start doing the second one. Maybe in the middle, we can start doing third one, and we can even start doing application for FDA. We can apply for sure, but maybe we can start preparing. I'm not really diving into the process how it really works in pharmaceutical.
Yeah.
But I'm pretty sure based, because we saw a video from Mark from Pfizer, how they shrink it and do it in parallel. But if doing it in parallel means that our cost structures change because now we spend all money at the same time. So if it fails, we lose more money. Honestly, it probably will not affect for such a drug, which has really huge potential for revenue because it's like hundreds of $1 million failed loss. But anyway, in case of the drugs with smaller amount of revenue, probably that won't be reasonable to do it all at the same time because if it fails, and it's like most likely will fail, we're gonna lose a lot of money.
One item to consider adding to your competitive analysis are investigational assets and other pharmaceutical companies, product portfolios as well too.
Yeah.
They will be competing with them. There's a lot of drugs that are being studied right now that are not approved in phase 2 and phase 3 that will be competing by the time that this drug is approved.
Absolutely. We have done it in the whole report. We put it even our own portfolio drugs because we kind of going to compete with them as well. We didn't consider this as a like pure competition. It's more portfolio optimization and like risk hedging because we want to have a drug like that. But anyway, we put it into the report, but we didn't put it in presentation because it's too much. So I think we start somewhere on this chart. Yeah. Yeah, honestly, this one was one of the most tough, but as we figure out, it should be slightly slower, should increase slightly high. It's for next team, so you guys need to improve it, and it should fall down. After some 10 years.
It's tough in phase one because you don't have a lot of data yet that has read out from your trial. It really, your chart here is going to be influenced on the standard of care changes, the changes in standard of care that the therapy offers to the market. How more effective is it, and how much more safe it is in approved patients?
That's a question I was thinking about. How are we gonna know it in 8 years?
It's hard in year one.
Right.
That's why you should have at this point, you're in phase one, right? So I would expect at this.
Phase
point-
one is not even here. Phase one is like here.
Yeah, where you're presenting right now, you started presenting,
Yeah.
you're in phase one right now. So there's so many unknowns that you're gonna have a very wide margin. A lot of the drugs that I've worked on over my career, the main competitive drugs are drugs that are in trials at the time they start trials, not drugs that are on the market when you're studying.
Yeah.
Because a new drug probably is more effective, right?
That's right. The FDA won't approve a therapy unless it improves the standard of care for patients living with that disease.
Also, if you just look at timing as well, you're talking efficacy, but timing, the products that are in the market today may very well be out of patent by the time you hit the market. They might go generic by the time they're, right? So in that sense, your contemporaries are the pipeline drugs from your competitors.
But the point that just was said that FDA will not approve just different drug with the same efficiency. It makes a lot of sense because there is no sense to do just different drug just to keep your new patent on another one, right? But you need to develop it better.
Yeah, but the point is when the drug goes off patent, generics will enter the market and substantially reduce the price that you'll be competing with your new therapy, unless you can show and establish a safety and efficacy profile that improves standard care.
Right, so like Keytruda may be off patent by the time you launch, and the price, the generic price will be much lower. You're now competing with Keytruda at a lower price.
Yeah, but probably our drug is better, right? It should be, at least.
That's what we're saying, is like the drug has to be better, it won't get approved, right?
And how we can know in which stage we can figure out that it's better?
Maybe stage 2 usually.
Yeah, that's why the data readouts and the milestones established in the clinical development program from phase 1 to preclinical through phase 3 are so very important. That's where you'll see the big stock changes in pharmaceutical companies is when they read out their milestones from their clinical development program. So, the last thing too, not to get too detailed, but you also have a combination of biologics and small molecules in your competitive profile as well too. Biologics do not have a cliff at the time the patent expires because usually physicians will keep them on the biologic even after the patent expires. They're existing patients. So you would only be really competing for new patients in the disease.
So it's more of a gradual decline.
Yes.
So based on this data, well, they figure out it's not very accurate, but anyway, we built this model. I think numbers will not really much change. It's still, R&D will still remain positive for this drug, even if it will change revenue stuff. So we got the best decision is to drop the drug, to continue to pursue this drug, to launch drug on the US market, and after to move it to the global ones. So starting from US, it of course might change in 8 years. We can realize it. And the R&D that we got is 1 billion. Last time it was about 3. Now it increased. This is pretty much all. Questions?
I'm going to keep track of your risk-adjusted NPV and your IRR so we can do some contrasting at the end with all the other projects. Okay, perfect. I just want to make sure everyone else is going to do something similar so we can keep track. Questions or comments about this team? First team always gets the most questions, right? I think first of all, you've done a great job, especially given your knowledge of the industry as well as just what you've learned in project management. This is a pretty comprehensive analysis. I don't know of any other industry that does decision tree analysis, risk-adjusted NPVs, and tries to predict the future 8 to 10 years in advance, given what might be limited data, right? So, all right.
Just add one more thing in there, so just because I run the patient access analytics.
Okay.
So I always think of the patient, right? So one of the things to think about, right? You did have a payer component in there, right? And I did see that you understood that there would be an out-of-pocket cost to the patient. So one thing to think about, what would be the patient support? Because for some of the, for some families, that 16,000 is a lot of money. So just to kind of think about how would you have a patient support and what would be your copay program to assist the patients?
So we kind of can discount the $8,000 that they have to pay from their own pocket, and we'll kind of nivellate the payment from them. But we definitely put the 8,000 into the drug price, so insurance company will pay. So we give money to the person who needs a treatment, he gives us back, but then insurance companies pay, something like that.
So there's a lot of different ways you can do that. Yes, so because sometimes there are, payers' reluctancies to cover medicine, and then but you need to ensure if a patient has a debilitating disease, right? As a company, you want to send for the patient to think through avenues how you can support the patient directly.
Yeah, directly. Yeah, it makes sense.
Yeah, and a lot of times the pharmacy benefit managers don't put it on formulary right away. It takes time. So it might be off formulary, and then they're paying the retail price, which is not a great thing for the patient.
Yeah.
I have one question for you, if you don't mind. So here we have this project cost. Yeah, this one. We were really struggling doing this because some of this data are outdated, some of this data are related to technology. And the biggest question we had when we were doing this one, do you working in an industry have more sophisticated data from your own company? Does the companies, pharmaceutical ones, build a data set inside definitely confidential ones, so you can do research based on their internal database, how you proceed with different stages and how much money you spend? Do you have all that? Or
I can't answer that because I don't work on Pfizer drugs. And I also don't work, when I work on the other company's drugs, they take it through clinical. So I don't have a good answer for that, but maybe.
Yeah, there are definitely a lot of internal databases.
We talked about third parties right before this session as well too. So CROs play a major role in the clinical development program, and they have a ton of cost models that they provide to pharmaceutical companies, but they change again based on the safety and efficacy profile, what comes up, what you learn throughout each of the phases.
The CRO is used to do clinical trials, right?
Oh yeah.
I know some people from such a company.
And in fact, they don't have to be in the same country either, right? So you can use CROs that are overseas, right? And that's part of their cost advantage and also part of their time advantage as well, because they can put more resources on it. They can work in parallel, they can take a higher risk. So
maybe even some regulation differences.
So it's, we want to run trials globally. One, because the US is a diverse country with people from all over the world, and drugs work differently in different people from different backgrounds. And so you'll see companies that have expanded their clinical trials. And then countries like Japan, which is one of the best pharmaceutical markets in the world to do business in, they require Japan-only studies with patients that live in Japan too. And so, yes, outside the US, clinical trial programs are becoming larger and larger. Yep. That's another thing to think about this too. It seemed like this was very US focused, the launch of this drug in the future, but Pfizer is a global company and they would probably want to launch this drug globally, not just in the US. So another consideration.
So look at where the regulations are and also look at where the market is in terms of, is there a market for this type of tumor outside the US? And if so, where is it the most effective, right? For you to go after.
Right. There is a market. We have a number, I think, and 60% is outside of USA.
Right. But I mean, it's more than just how many people get the disease. It's also what their reimbursement plan is and how they can compensate you if they can't afford your drug. What was it, $12,000 a month or something, right? I'm not sure of too many countries that can support that, including even this one. So.
Well, the US is the only one that doesn't have price controls, so you're gonna run up against price controls in other countries. And, you know, then that's why sometimes the US ends up.
So footing the bill?
Exactly.
Well, I told the students up front, expect to see that the US is subsidizing the R&D for the world effectively, right? So, and part of that gets monetized in the price of the drug here versus elsewhere, right?
The current HCV drugs that were approved about 4 or 5 years ago, I actually was on the launch team at AbbVie for the Curapac against Harvoni. That's a good case model in terms of the price of that therapy in the US versus Egypt and other countries.
Excellent. Okay, thank you very much. Nice job. Let me do this, have one more team and then take a break. Can we go to team 5? So team 5 has a drug treatment for lupus and other, and I guess rheumatoid arthritis, right?
Where's the mic?
Use that one? Can you guys hear us okay online? Yes.
Yeah.
Okay.
Is it possible to get the panel up front so when they're talking, they're too far away?
Well, maybe I can do this instead of moving the team. Why don't I just move the camera? Right. Is that better? Is that better?
Yeah.
Yeah. Take going.
All right. So good morning, everyone. We're going to be talking about our project estimation for drug PF06835735. So it's an autoimmune drug. We're going to get into it, but it's for treating lupus and rheumatoid arthritis. My name is Andrea with Colonel and Chinmay. Next slide. So for some of the topics, we're going to talk about a little bit of background, drug information, competitive products, and we're going to talk a little bit more analysis about risk, project timeline, cost, success rate, and we're going to get into some of the numbers behind our drug, market revenue and key analysis, and our decision tree, and we'll be finishing up with some risk mitigation techniques that we thought about in our conclusion. Okay, so some background on our drug, like I said, it's used for treating lupus and rheumatoid arthritis. Delivery mode is primarily intravenous or subcutaneous injection. It's a biological molecule, and the way it works, it's a chemokine inhibitor, so it prevents inflammation caused by lupus and rheumatoid arthritis by inhibiting chemokine functionality. Therapeutic indication is immunology. It's a molecular entity. And it's currently concluding phase 1 trial. So recently, status was supposed to be concluding in February of this year. We're still waiting any updates on that. For some of the competitive products, the main 2 ones on the left, Saphnelo and Benlysta, are for lupus. Benlysta was approved back in 2011. Saphnelo more recently last year in 2021. And there's a lot more drugs for rheumatoid arthritis. We have 3 of them here, but basically the main ones that we want to focus on are Saphnelo and Benlysta. So yeah, and I believe just some quick numbers. I think Benlysta is projected to have around a 20% market share in a few years, so that would probably be our main competitor.
Okay. So for the risks that are associated with our drug project, there are 4 fundamental parts that we found. So the first thing is the current status and the delays. So because of COVID, I mean, we're not actually sure whether it was because of COVID or not, because they didn't actually provide the explanation. But they actually started in November of 2017, and they went on like for further delays for their phase 1 and they actually just started in 2019. So that's why they were planning to conclude in in February of 2022. So and then the other thing, the next possible risk is the funding risk because of those delays and because of the already existing overhead costs. If they plan to cancel this development or something, it will be really expensive, and it gets more probable by the year, especially if there are more and more delays. For the technical risk based on the existing drugs and treatments, or SLE for the lupus, 28% of the drugs that out of the 74 samples that we had proceeded and was marketed. However, there were 20% that ended up either being terminated or withdrawn. For the RA for arthritis, 75% ended up being withdrawn, and only 10%, almost 11% ended up being marketed. And this was from 118 sample RA drugs. For the FDA approval risks, there was an increase of rates of approved drugs by FDA. However, due to COVID starting in around 2020 and 2021, there have been a stagnation. So there might be more difficulties for the FDA approvals. We hope this won't happen though. For the system, sorry. So for our estimated project timeline, we are estimating this will conclude in 11.5 years. And the reason for this is because they had a lot of delays for phase one. That's why for phase one, we put 1,100 days because of the delays. And overall, we plan this project to conclude in 2032, which is a total of 15 calendar years.
For the cost analysis, the base data that we had was from 3D09, and that was approximately 21 years ago. So what we did was we found out the phase 1, 2, 3 remaining costs, and we extrapolated that to the current 2022 data using the inflation rate of 4.5%, which is true to the United States. And we found out that the total overall cost for the drug development would be 825 million. And most of it is going in discovery and preclinical, where we have gave some bigger room when it comes to the entire project. So the total cost of this particular project would be approximately 825 million.
So we ran some studies, did some analysis regarding the success rate of this drug. So we had some numbers from some historical data for different types, the parameters of the drug. Say it's a new molecular entity, it's a drug for immunology. So we ran some analysis, and we actually reached a number which was 35% success rate for FDA approval, which we felt that it's high compared to the history that we have for phase 1 drugs. So what we did is we also had some data which shows from 1997 to 2002 for all the phase 1 products. We saw that there's a decline in the success rate of the drugs for FDA approval. So as you can see, it goes down from 43% to 19%. So what we did is we extrapolated it to 2022. And it just went, and actually we got a good model. You can see the R square is 0.9, so it's a significant model that we got, and we got a result of 12%. But since you can see that the data is quite outdated, it's until 2002, and we just wanted to have another check on this number. So we searched on the internet and we got some recent studies which were done by some research institutes, and the data was very recent. It was 2011 to 2020, and it showed that autoimmune diseases, the success rate is around 10.7%. So it kind of matched, it was very close to what our result was. So I think the projected success rate based on our analysis is 12% for this drug. Now we'll go for the market and revenue potential. So for the lupus, it's 1.5 million cases in the US, and for arthritis, it's 1.3 million. So that was our starting base point. And as Andre mentioned before, our competitive drug is Benlysta, which is having like 14 doses per year. So we took that as a base point. And the price of the drug is around $2,000 for 400 mg, and the dosage is usually done based on the weight of the patient. So we assume since lupus and arthritis is mainly found in women in the US, so we kind of took the average weight of women and then we calculated what will be the drug, the dosage of the drug. And based on that, we calculated some figures. So sure, what we did was, since the development started in 2017, and we have assumed like it will take 15 years. So considering that we will have, once we get an FDA approval, we'll be left with 5 years period until the patent expires. So we calculated the overall revenue for the next 5 years after the FDA approval. And we felt that the first year we'll be covering the market size of 2.5% for the overall population of lupus and arthritis. So we have ramped up from 2.55 and we went ahead to 12.5. That was just an assumption. And based on that, we came up with figures where we feel that the revenue will be 57.4 billion, which will be for 4 or 5 year period. So that's the potential of this drug.
That's in the US, right?
Yeah, that's in the US.
So based on the explanation that Chinmay just gave, we plotted the decision tree for the most likely case scenario. That was based on the price of dosage at $4,000. So based on this decision tree, we can find out that we have a positive cash flow, and from our end, it would be a go ahead with the project. Now, along with decision tree, we found out the RNPV. So we had some research regarding the discount rate, and we found out that for various pharmaceutical companies who are doing drug development and IPRD, which essentially is in process research and development assets, the average discount rate is approximately 13%. So we took that into consideration, and we divided the timeline from 2017 to 2026. And we found out the discounted factors, the undiscounted cash flows, and we converted that into the discounted cash flows. But considering just the NPV is not enough, because when it comes to revenue, there are certain risks associated with that. And we already know that the success rate of project is approximately 12%. So we took that into consideration for finding the RNPV. And we can see that for the most likely case scenario, the RNPV is coming out positive. So that is a good sign to go ahead with this particular project. Moving on. We also found out the worst case scenario wherein the drug would be priced at $980 for 400 mg. And keeping all other factors constant, we found out the NPV and RNPV. We can see that the NPV is positive, but if we take the risk into consideration and probability of success as 12%, we can see that the RNPV is coming out to be negative. So we can conclude that the pricing for this particular drug cannot be 980, it has to be higher than that. And on the similar lines, we found out the best case scenarios where the price of dosage would be 2,300, and we carried out the same calculations. So depending upon various considerations, we can see that the RNPV is drastically changing. But based on these three scenarios, we found out that the most likely scenario would be slightly realistic, considering the competitors that we have in market and their own pricing when it comes to this particular drug.
Thank you. So there are a couple of risks we identified that could result in a delay of the project or maybe like hinder it. And so there's risks involved that involves cybersecurity, data management, and technical problems that might arise during the project. And for us, what we will do, like for what the project should do for the mitigate these risks, for example, for data integrity. First of all, develop a routine system inspection, update the software, especially for projects that involve a lot of sophisticated computer systems. establish a process data cycle is really important, especially for the overall documentation and the destruction of the data to make sure they don't spread out. For the big data management, mitigation to electronic systems, especially for metadata, where it could get really complicated, and the inclusion of AI to make everything more seamless, to make data browsing easier for the companies. For technical problems, concrete mitigation plans is important, especially for technical areas. This is the overall project mitigation, but for each technical aspect of the drugs, their own mitigation plan would be needed. And the second thing is close collaboration with lab personnel and other stakeholders to contain the risks that are associated with the project.
So finally, to conclude, we'll just wrap it around whatever we just saw in all these slides. So our estimation for the total completion of the project is 15 years. The development is started in 2017, so it will get completed in 2032. Total project cost estimation is 0.8 billion. The revenue potential, as we saw, the most likely case is 57 billion over a period of 5 years after you get an FDA approval. And the risk-adjusted NPV was 66 million. And overall, we feel that it's a great technology that should be coming in the market. Obviously, we have another drug which is in pipeline. Pfizer, we'll be comparing the results with that drug, and we might come to a conclusion where to decide whether we should go ahead or just reject or deny the drug. So that's the whole summary. Thank you so much.
Okay, thank you. Any comments?
Just one or two comments. First, on the product success rate that you presented earlier in the presentation, is that based on FDA approval alone, or are there other factors that are driving product success rate?
Yeah, so it actually includes the phase one to the transition success rates as well. So I think, I don't know if you have a slide for it. No, I don't have.
No, we
so
included that.
We have considered the success rates for each transition between phase 1 to phase 2, phase 3, and then we also have the FDA success rate. So it's like all combined.
Yeah.
But ends at FDA approval.
Yes.
Right?
Yeah.
One of the things to consider is sometimes products fail after FDA approval as well too. So a clinical trial is a well-controlled environment where investigators or doctors that are part of the trial are ensuring that patients are 100% staying adherent to the treatment protocol. In the real world, after FDA approval, patients go and pick up their prescriptions and like hopes and dreams that they're adherent, right? And so you see different safety implications and efficacy implications post FDA approval that will sometimes drive label changes from the FDA, or the FDA even taking the product off the market as well too. And so that's another layer to consider when you're determining product success rate, is post FDA approval changes that can happen to the label.
Is that the phase 4 that they call it? Once the drug is out and they kind of modify the dosage depending upon the results that they get?
So a lot of, phase 4 trials are, post-marketing observational studies is what they're referred to. And that's a component that could lead to label changes. But then there's also just independent pharmaceutical registries that are not run by Pfizer or AbbVie or Horizon, that they're tracking the safety and efficacy data in the real world too. That's completely independent from the company that's manufacturing the drug. And the FDA is continuing to look at data that's going into those registries post-approval, and they will potentially make label changes. As well, another key factor in terms of the success of the drug post-approval is clinical guidelines as well too. So each therapeutic area, RA, hepatology, oncology, there's a team of like the top doctors in that therapeutic area that essentially write guidelines that the entire rest of healthcare professionals will follow their directions when they're making treatment decisions. And they will they'll make changes to their guidelines that ultimately inform future prescription decisions that are critically important. Then the last thing, sorry to be long-winded here, in RA, which I'd say a lot of these drugs are biologics. So to the comments on the last slide, there's not a cliff once the patent expires, because many existing patients will stay on their drugs that they've been taking up to the point when the patent expires. And so the decisions that payers make in the US in the RA space are critically important. That's why Abbott, AbbVie, and Pfizer have been so successful with Humira and Enbrel, are two of the highest revenue generating drugs right now that are on the market. It's not necessarily their sales representatives, in my opinion. It's the deals that they've set up with payers to put their drug at the top of the formulary list for all patients that are insured from those insurance companies.
Okay, any other comments? I guess your risk analysis to me did not seem to deal with many of the clinical risks, clinical trial risks that might be incurred. So you might want to look at what are the likelihoods of failure, what were the causes of failure in prior submissions and prior drug developments, because I think yours is more data oriented and cybersecurity oriented. So just think about what's actually caused projects to derail in the past. From that, let's take like maybe a 10-minute break, come back at about 10:40. We'll start up with team 4, and maybe team 4 can set up while we're at break. Also, did you guys have any project openings you wanted to talk about, Olga?
Oh, yeah, I love that.
Okay, you've got
Let
everything.
me know when is a good time for that.
Okay, you want to, well, we can do it right when we come back from break if you like. Okay, sounds good. So Olga will talk about the horizon of pharmaceutical project opportunities that are still open for you guys. So keep your eyes open for that. Okay, be back in 10.
Four months for us, R&D.
Yeah, I'm in the big clients.
Enjoy.
I've worked outside the US.
Got it. So yes, so David.
I worked at Abbott. He worked at Abbott, but decided to we got over here 4 months ago. Once Horizon decided to expand outside the US. We're expanding to this initiative.
Everybody, you know, all the different highlights, the 400 openings. Yeah. I'll say, so we work with David occasionally because
with Megan too, probably, right? Megan Downs.
Yes. Oh, yeah.
Greater programs that bears are federal healthcare program beneficiaries from access to Medicare benefits. So.
And then the impact on best products.
Oh, yeah. There's lots of risk. Okay, cards in our space for commercial patients because in many instances our drugs are buying drugs. Doctors make not doing the money that's that does raise quite a bit of anti-inflammatory when the doctors and non-Medicare Medicaid it's
yeah. But at the same time, there's no one who's not to have that. Right? Yeah, it's always the balance of that.
Yeah, the patient has to be our North Star.
Yes.
Sometimes.
Yeah, it's okay.
How long have you worked at Verizon?
So a little over a year now.
Where did you come from?
Yeah.
Oh, that's right. You said that. I'm sorry. So that's how you know Dave's time.
Yeah. So yeah, 13 years into different analytics functions. So now I have the peer analytics, sales analytics, reimbursement analytics, analytics, and patient analytics. So we work a lot with Kelly Alice. Yeah. Exactly. Very interesting because I had to set up my own team like a year ago and I was N1. Offshore.
What else you would add this?
I'm good. I mean, I'm not going to talk about this.
This is great. We're talking.
No. I just wanted to make sure that, we're not too far off. So, of course.
I think about too, you know, where I was at.
And all of it is for reading, I mean, not for working, not for being in the industry. It's all from data sets, data sets. It's really what they can do. Right,
From just reading.
yeah.
It's like they're doing a really good job.
Well, I think some of them are actually interested in the industry. They didn't necessarily start out that way, but I think they're starting to become interested, so. I can give you guys maybe 5 minutes and I'm putting in 5, 10.
Oh, yeah, yeah.
All right, well, you got a mic, so I'll turn it over to you with the mail.
So you have a program too?
Yes, you guys have a project, remember that? Yes, I have Pfizer.
My project is similar to project.
You know, we're really impressed with the Verizon. It's really good.
Actually,
You guys,
I've noticed that Peter was there.
yes.
You guys are so far ahead. Okay.
Great job.
Yeah, we did it really well.
A lot of.
Oh, yeah, we did it that.
Industries there, talent is there.
So do you think that you guys are hiring and with these kind of guys qualified for openings or?
Well, they would have to apply, and then yes, so right now I'll speak to the project that I have. The nice thing about being a project like that, we do have an opportunity for them to expose.
It takes a lot.
Does anybody just like an internship this comes?
Or even a full-time position. So even the folks that I chose, I have a senior position, which I open at my team right now, they wouldn't even qualify. So I want to get them, I get this started, and even in my senior position. Yes, we do, and I do that as well.
Well, you guys are one of the biggest options.
You do sponsor it.
A whole nother level.
Did I tell you?
So they don't take one shows you a lot of implementation, a lot of combination.
You have to go to the tree. Don't go to the store, go to the tree. This is, you can pluck the fruit right off the tree.
Yeah, I appreciate it.
So I really appreciate having you come, and that's your project perfectly timed, because this class really often once a year.
Really?
Yeah. When it came to my desk, right with this class was like in week 6.
Yeah, you made it, and I still one of the friends.
To be able to meet them.
We'll be able to meet them, exactly, yeah.
Right. And I think I should have one further.
Yeah.
Okay.
It's already.
Why don't we just say technical and
All right, team 4, let's get set up. How are you?
We just took this just focus on this words.
Anyway, thanks a lot. Thanks,
These 4 points.
Okay, well, before team 4 presents, let's try to get everyone back in the room if we can. Georgie, can you help us? Let me just ask quickly, who from this class is already participating on one of the Horizon projects? We have 2 Horizon projects. Okay, excellent. We're gonna have Olga from Horizon talk about her project. She still has 1 opening, not just for the project, but she's got full-time permanent openings as well on her team. So a good job on the project might very well lead to at least some sort of interview for some of these other opportunities. So Olga.
Thank you so much, Professor. So I'm Olga Muchnik. I run the Patient Access Analytics team in Horizon. And I have various functions under me. One of them is the payer analytics, understanding the landscape of payers and access to our medicine. The second is patient analytics, which is more about the journey that a patient takes to access, our drugs. Meaning after a decision has been made by a doctor and the patient that that's the right therapy to pursue, it can take up to 6 months sometimes for the patient to eventually get to that first infusion that they need. So my team looks at the various aspects that the patient has to go through after they've been enrolled. And we have really robust patient services support network to help the patient get on therapy. And my team analyzes the data in all the various stages that a patient goes through and identifying kind of the bottlenecks and where the patient could get stuck in the system to see how we can inform our patient services organization to support the patient. They're also looking at various coping programs, again, very oriented around the patient. How can we help the patient get to therapy? And the project that I have right now is a 10-week project through your school in partnership with Northwestern here. To where I have 5 students from the graduate class here from this program who will be working on looking at the data, this patient journey data that has so many different aspects from insurance, from approvals, looking at the various de-identified, you will not have access to obviously patient information, but de-identified patient level data to see kind of like the trees that I'm seeing here, very similar to be able to design some type of a tree like this to identify where we might potentially have patients who are struggling, lost in this access journey, and how we can get them to therapy. So that's the project, to really work with the data, create some visuals, and then at the end of the 10-week program, you would present that out to our Horizon leadership with some of your recommendations and maybe some of your findings and where you're seeing the patients could be getting stuck. So that I have one opening on that. That will be a class that will be on Wednesday evenings. And again, I'm meeting with my team who already, I have 4 that I already selected. One more person I need to still select. I'm meeting with them next Friday to kind of talk through all the details. But the idea is that you would be able to come on site to Horizon every Wednesday. It would be a commitment of about 7 to 10 hours a week to work on this project. And then after that, we do have a lot of openings in Horizon in our analytics department. Actually, I have one on my team, but I also have, we actually have 15 altogether in our broader analytics team. So that definitely would give you exposure to understand all the openings. Thank you.
Oh, thank you, Olga. Okay. I don't know, Zoe, if you had anything you wanted to add or?
Sure. Did you already talk about our project? Do you want to talk or you want me to talk?
Whatever you prefer, so.
All right. So you just want us to talk about our projects? Or
Yeah, I guess if
about...
you're still looking for help, basically this might be a good pool of candidates for you, so.
Sure. Okay. Hello. All right. I'm Zoe Hefner, and work with my colleague Tom Zierl in international at Horizon. So Horizon has recently decided, recently as in like 2020, decided to take our portfolio of products into the ex-US marketplaces. So we're launching our drugs in Europe, Latin America, Japan, and potentially other areas. We do already sell our products in Canada. And as part of that, we we're basically building all of that not fully from scratch, because obviously we have the US business and Olga's team and people like that to support us. But we're embarking on an entirely new endeavor for the company, and so we really have the opportunity to set up new systems, tools, and processes that are going to be fit for purpose for each one of these markets. And so one of the things that we have to do within the commercial organization, I work on international business operations, which is basically the backbone of all commercial. We have to think about how we interact with our customers, namely healthcare professionals in ex-US markets. And so you can think about all the different ways that a pharmaceutical company would engage with physicians, right? You've got actual sales reps that are going out and talking to physicians, will you write a prescription for my product? You have medical affairs who are like doctors and scientists that go and speak to physicians. You have patient advocacy, which is helping for patients, helping patient organizations understand what they can do to support the patients, get the patients what they need. You have government affairs, you have market access teams that need to make sure that policymakers and payers understand the value of our medicines and can expedite the access that patients might have to or approve the access in some countries, right? You get approved for the drug, that doesn't mean somebody can buy it, right? That doesn't mean a patient can get it. And so we need to engage with physicians in a lot of different ways to help us understand what's the best thing that we can do to support them to make sure that patients get the best treatment that they need. So we have them advise us, or engage with us all along the commercialization life cycle, from phase one, and even before phase one, all the way through post-market, right, to be in helping us to understand what we need to do. So we often have to contract with these physicians to pay them to consult for us, right? And so one of the things, our project is to help us define our HCP consulting platform for all ex-US markets. So this would be, we need to understand what are our requirements. There's different regulatory requirements from a compliance standpoint for reporting in all of the markets. Not only what money we give them, but how often we engage them, where they're engaged across our organization. So understanding those requirements, documenting those requirements, and then actually making recommendations and building the tool that will support us to do this. And across, we want to have a single source tool for all ex-US markets and maybe even US too. But you don't disrupt a $2.5 billion US business, right? So we're not going to, the goal would be to try to create a one horizon solution that will allow us to compliantly engage and report on our engagements with HCPs. But then beyond compliance, right, it's a reputational risk also that we're trying to reduce, because as an organization, you want to make sure everybody knows what everybody else is doing to the best of your ability, right? Like that's what most of project management is. It's just communication, what we're doing, so everybody knows. Helping our organizations across access, medical affairs, commercial, government affairs, patient advocacy, understand how we're engaging so that we can more efficiently engage in this. So that's the project, and it's really exciting because, we're launching in 20 plus markets in the next 12 months, 18 months. And so you'll be really helping us build something completely from scratch. So, yeah.
Okay, thank you. Thank you. All right, nice to hear from you. I'll point out the MEM students are schooled in writing requirements. We have an entire product management concentration, and we have some of the best instructors in the world teaching them how to write PRDs, and also in the field of analytics. So we've got probably plenty of candidates for both of you guys if you guys are interested. So, please feel to network with these folks after the class is over. With that, Team 4, take it away.
Hello, everyone. We're Team 4, and we're going to talk about the portfolio estimation and project valuation for reciprocity. First, I'd like to introduce my team. We had Adana, who was our conflict resolution manager and a research specialist. We had Nagarjuna, who worked on the research and analysis bit. Suraj was our resource manager and final sign-off, and I was serving as the project manager for this project. So we'll start off, and Nagarjuna will start talking about reciprocity and achondroplasia.
So, it is dwarfism. Achondroplasia is nothing but the dwarfism. So it has many symptoms apart from standard growth. So you see, they'll be having these dot legs.
You can use this one if you
want. And there will be curved spine and a big head. Apart from that, there are a lot of symptoms also. And in some cases, it also causes neurological disorders even. So that condition is it is not entirely hereditary. So it is in 80% of the cases it occurs during the embryonic stage. And reciprocity is a drug tries to nullify the effects of achondroplasia. It actually acts as a decoy to the FGFR3 malfunction. That is the main reason of achondroplasia. So actually, Terracon started the research, and Pfizer acquired it from Terracon. So Terracon already did the preclinical and phase 1 research. From there, Pfizer took over it, and currently it is in phase 2.
So yeah, basically the competitors for this are Voxzogo, Ascendis Pharma, and Unity Therapeutics. And Voxzogo is the only competitor who has, finished and actually the drug is out in the market. And yeah, Ascendis Pharma and QED Therapeutics, they're basically in phase 2, like as with our drug, which is Resiprazil.
We divided our risk into two types. It's the development risks and market risks. Development risks consists several risks like limited knowledge base because of rareness and complexity of disease. Ensuring the quality of patient data, effectiveness of and safety proof, low clinical trial enrollment, and also transitional risk between phases. Also, risk market, it's really small market because of rareness of achondroplasia. It affects about 1 in 15,000 or 40,000 people. So, and also the pricing question. Working on a rare disease is difficult task for organization because the market is tiny and it affects on the price of the drug, and it turns in great burden on the patients and insurance.
So going forward, we had to decide about the timeline estimation for the drug. We took three scenarios into consideration: the best case scenario, the most likely scenario, and the worst case scenario as well. Since phase 1 began for the second time in 2020, and currently we are in phase 2, we expected the best case scenario where phase 3 goes on really well and we get expedited approvals from the FDA. For that would continue and we would finish that by 2025. Our most likely case scenario is at the pace that we are currently going on, where phase 2 has been slightly delayed by 10 months because of lack of quality of patient data that we could acquire. And in this scenario, we would see that the drug would finally go to market if it passes through all the phases in 2027. And the worst case scenario that we have assumed that it would go to 2029 because of a delay in phase 2 and a significant delay in phase 3 as well, where we would require more number of patients to actually test the drug. So we're doing the cost estimation after this, and Suraj will be explaining the various steps that we took into consideration to actually come to the total investment there.
Yeah, before cost estimation, a slight history. So in 2019, Pfizer actually bought a company called Telecon, and Telecon was involved in researching with this achondroplasia and one other disease. And they were invested totally of 40 million and 60 million for each of those two research, out of which a total of 42 million was put into TA46, which is basically the drug that Pfizer bought. So that we accounted as Telecon research, which is 42 million. And Pfizer bought Telecon for an upfront cost of 340 million. So after buying it, they had basically TA46, which then had to be purified, and we are estimating the purification cost to be around 20 million. And then so the total preclinical cost for Pfizer has been around 402 million. And then we have the typical IND filing phase 1, 2, 3, and the NDA cost. And then Pfizer has made a commitment to Telecon that there will be an additional payout of 470 million, but that is only when it reaches some undisclosed milestones. Yeah. So for the next one, we're going to talk about the worst case scenario for cost estimation. So worst case scenario is pretty much the same, except for the phase 2 and phase 3, where we have added 25 and 54 million, because we are accounting for the swelling of phase 2, and even phase 3, which is supposed to be completed in generally 2 years, it might take a maximum of 4 years. So that's why we are accounted for 54 million in excess.
So next we'll talk about the global market size. So considering the most likely scenario where the drug actually goes to market in 2027, we extrapolated the potential population of the world in 2027, 2028, and 2029. From that, we assumed that 18.25% of the population would actually be children between the age of 2 to 11, which is actually when achondroplasia can be treated. Out of that, so we got the number to be between 60 to 62,000. From that, we had to consider that 50% of these children would not be eligible for reciprocate because of comorbidities, and that brought our number down to 30,000. And considering that adoption rates for such a drug can be low in the initial phases, we assumed that it would be 5% adoption rate in the first year, 7% adoption rate in the second year, and 10% adoption rate in the third year, which actually got a serviceable, obtainable market to somewhere between 1,520 patients worldwide to 3,094 patients in those 3 years. And the population for the same for USA would be between 300 to 1,000 patients, 300 to 1,500 patients over a course of 3 years. So let's talk about the revenues here. So reciprocate is a drug that has to be given through subcutaneous injections, and you would require about 260 doses per year. So per patient would require about 260 doses per year. We took a industry standard, a discount rate of 11%, and a corporate tax that would be applied on the drug at 21%. So taking these calculations into account and seeing how Voxzogo has priced their drug currently at $899 per dose, we took the inflation rate to be 2.2% and came to calculations of around $1,000. And we wanted to price the drug at $999 per dose for the first year, $1,019 for the second year, and $1,049 for the third year. So after doing that, we got the estimations to be close to 333 million and about 498 million and around 660 million. From this, we subtracted our operating costs. We subtracted the corporate tax estimates included as well. And then our numbers came to about 233 million in revenue for the first year, about 343 million in the second year, and around 529 million for the third year. So this is our gross revenue after subtracting everything that we expected Pfizer to make from this. And after this, we calculated the RNPV and the internal rate of return on the basis of these same calculations.
Yeah, further information, 1 in 25,000 people get affected due to dwarfism. So here is our RNPV, NPV and RNPV estimations. So you can see the RNPV for preclinical stage, it is 123 million. And we considered the risks of 21%. Here the probability of success rate is 21% from the decision we have made. And we considered 11% as our discount rate. So we estimated it from the Pfizer's historical average. So here is our decision tree. In phase 1, phase 2, and phase 3, we consider the probabilities. We also consider them from the historical averages of Pfizer. Finally, we have this 21.2% of success rate of the project, and with a RNP of final RNP of 734 million.
So talking about the regulation strategy, Pfizer is basically conducting this preclinical and clinical studies in Europe. So we are hoping to launch first in the Europe, but also while applying for the EMA approvals, we will be simultaneously applying it in FDA as well. And here in, I think FDA, most of the teams, like the 2 teams prior to us have already spoken about it. And I'm going to speak about the route that EMA has to be taken. So there are basically 2 roads. One is centralized road, and then is nationalized. So when you go to centralized road, you will have access to market in all of the European Union states. And if you go to the national road, then you have certain nuances in that where you can collaborate with few of the states, or do you have to take permission, but you get to market it in individual countries over there. And then there are certain mandatory requirements when you're marketing it in EMA. So basically, reciprocate, as it's an orphan drug, because it's extremely rare disease case, it has to be considered under the centralized route, and we'll be taking that route for progressing forward. And then generally, when we go to approvals in the European Union, it takes more time in Europe than in USA. So roughly about, the median is about 320 days for FDA approval, but in the European Union case, it's about 366 days. So you will be signed by about a few months roughly.
We expect like commercial successful in time because as Yash told, the price of Reciprocept, we consider it's going to be per injection around $1,000. So it's going to be $250K per year per patient. So we expect a commercial success, a low adoption rate around 5%, but in the first year, but in 3 years, it's going to be 10%. So there's 4 exit strategies. First of all, it's continue research on alternative similar disease. We try to find disease with bigger, wider market size. It's Noonan syndrome, and the occurrence rate around 1 in 1,000, 1 in 2,500. So there's some advantages of this exit strategy. It's a possibility not to throw away the already collected research for nothing and all the wasted money. So also, as a disadvantage of this strategy is that knowledge transfer can be difficult in the case of, it may be dependent and influenced in a lot of factors we don't know now. So also possibility to trade bad to worse case due to low occurrence rate of similar diseases except of Noonan syndrome. Also, the second option of exit strategy is combined a study with a similar disease profile. It's combination of drug targets have the potential to overcome the limitation of their one drug target. It helped to make wider market size, so it covers. It helps to make high profit. So also possibility of covering more endpoints, so without need of multiple drugs. Also, as a disadvantage of this option is also its difficulty to make interchangeability between these diseases. We also don't have enough data to understand is it that they have like similar causes, and so also it may take a very long time to test back for another disease experimental. So the third strategy is partnership with another biotech company. As an option, we think it's good to partnership with the huge markets as China and India, because it has a lot of advantages as lowering the cost. Also, it has a disadvantage as a complication in terms of obligations, prices, and dividing profit. The fourth one is abandonment of research, but it's like the worst option of the exit strategies because you waste all the money and also you just throw away the research.
So considering all the things that we have discussed here, we have a positive RNPV, we have a good internal rate of return, and the fact that Reciprocept is a drug which is in consideration for such a rare disease that doesn't have a lot of solutions in the market. Even our competitor Voxzogo has a different endpoint. where their primary focus is the velocity of growth. But in our case, Reciprocep would actually provide a better quality of life for the patient as well. They would have improved facial features as well. Their spinal structure would improve. And keeping all these factors in mind, we thought that it would be emphatic to actually go with this. Keeping in mind that the RNPV is also positive and the internal rate of revenue is good. Yeah. Thank you, guys.
Thank you. Any questions for team 4?
So, I'll say that Pfizer has a rare disease franchise completely separate from other franchises, and I don't think these kinds of drugs are, pitted against other bigger drugs. So I think this was a great presentation. Thank you.
You did a fantastic job. Horizon is rare diseases. And one of the things that's, obviously the most rewarding thing about our entire industry is we make a remarkable impact on patients' lives and their families' lives. And rare disease is another benefit from a business perspective is if we can find or get breakthrough designation on our therapy, the government gives us a fast track pass when we submit data for another therapy too. And so if it's a highly competitive market in the clinical development space, it expedites our company's approval of a different therapy that would treat a broader population as well too. And so that's another business benefit of being in the rare disease space. And then as a compliance legal professional, I really like the regulatory slide. That was nice. And you hit it right on the button. I was very impressed with your understanding and command on the centralized authorization process by the European Medical Agency. That was great. And a big difference in Europe too than the FDA is in the US, when the FDA approves our label, like the next day we can go out and start promoting the therapy. In Europe, a lot of countries, after the EMA approves the therapy, there's additional regulatory milestones that need to be met before we can start promoting in those countries. That could take a year or 2 years longer.
Yeah, and the only other thing I would say is, for all of you guys, is just consider that the price you're going to charge in the US is not going to be the price you're going to get overseas. So just consider that for future.
So we assume that cost because most insurance companies in USA would not consider achondroplasia as a part of their insurance policies as well. And currently we are seeing Voxzogo being priced at $899 per dose, and you get packs of 10 doses at once. So owing to that, that was our estimation. And one thing that we completely forgot to mention is that Reciprocep is not patented yet. So there's a lot to explore on that front as well.
Yeah.
So, yeah.
Good job.
Yeah, great job.
No, I did. I wanted to point out the regulatory slide was quite good. It showed that you were looking beyond the US market. I'm curious about the parallel path approach. Does that compound the risk? And is there any reuse in terms of data between the two agencies that you could mention? I also like the exit strategy slide, but the last option was framed as you don't want to do this because you'd be wasting your investment. Well, that's the sunk cost fallacy. Don't fall into that sunk cost fallacy, right? Don't justify past expenditures by spending more money in the future. So the only reason you would drop the investment at that point in my mind is if you have a negative NPV or you've got a slew of other programs that have higher NPV, in which case you don't have enough resources to cover them all. But bottom line is this is a tough call because you've got a small market, you've got the rare disease, you've got a very expensive procedure. It's $250K a year for how many years? 5?
No, it's not 5. It's approximately somewhere between 1 to 2.5 years per patient.
So let's just say 2 years, $500,000 in treatment, right? For a relatively small population.
I mentioned that abandonment is going to be the worst case because you can change and start researching on their similar disease. It's better.
Right. So the reason why we just mentioned that to be our worst case is also because of the lack of research that Pfizer currently has with respect to this. I mean, there must be a lot of research, but we did not have access to this as well. And because one thing that needs to be kept in mind is on the basis of however milestones are reached, Pfizer is still going to pay Theracon about $470 million. So if they're not going to be able to achieve the targets that they want to, and at that time, abandonment or transferring it to another company would be the worst case scenario that we could actually.
No, I accept that it's the worst case. I accept that. I'm just, the rationale for it that was stated was sunk cost fallacy. I don't want to fall into that trap, but so that's an interesting point that you made. 470 million has to be paid to the originator of the technology, independent of whether this goes to market.
So from what we were able to interpret, I think it's upon completion of various phases.
Okay.
We don't have that information.
So if
But
they choose not to go to market, it still has to be paid.
Yeah. Okay.
So you complete the
If
phases.
it goes till phase 3, they still pay them some amount of whatever has been promised so far.
Okay. All right.
Interestingly, we've had incidences where Pfizer will divest a drug to a third party, and then they'll come back to us in the Pfizer Center 1 manufacturing to actually help them develop and manufacture the drug. So Pfizer won't own it, but we'll be making it. So this is not an uncommon occurrence.
Got it. Okay, thank you. Let's move on to team 3. Let's try to keep presentations to maybe 10 minutes if we're going to try to get out of here on time. So team 3 is also working on something called Decavil, which is for treating autoimmune disorders. So we can at least mentally compare it to team 5, which was also working on autoimmune disorders, right?
You want to share the screen?
Yeah, just share the screen. Okay, team 3, take it away.
Hello, everyone. A very good morning. We are team 3, representing Decavil F81IL10. My name is Divya, and we have on my team Soumya, Nigel, and we have Liam over the Zoom. We have worked on this final report and with the agenda for drug purpose and its basics, and we're going to have a background about it, its FDA status and patent positioning, and Soumya will be explaining about market overview and analysis. We'll have a portfolio analysis, landscaping, and cost and schedule estimation will be explained by Nigel. And as we proceed, we're going to have a risk analysis done and a project scheduling process and a commercial success probability. And lastly, we are going to recommend our go and no-go market strategies and our exit strategies for the drug. Our drug Decavil F8IL10 is a treatment for autoimmune diseases, and it is targeting rheumatoid arthritis and other groups as well mentioned about it. It is basically a partnership project in between Pfizer and Philogen. Philogen is a company, a Swiss-Italian company, which is a biotech-based company who has been working with Pfizer to invest into this project. And further, we have a basic background about what is rheumatoid arthritis. It is a sudden inflammation seen around the joints, and it is commonly seen in women. And according to our data, we see that 2021, 14 million cases are occurring. And then for its FDA status and patentability, it's currently in the phase 2 of clinical trial. And as of now, it has been very promising that it did not show any severe effects in the events, and it is safe to use. And according to the patent, it was filed in 2008 and is valid till 2028. Now, further, I hand over to Soumya, who will be explaining us about the market overview and analysis of it.
Thank you, Divya. So, so it's a huge market, right? So our disease are mostly based on the prevalence of population, and you see there are a lot of people suffering from this kind of arthritis. We based our market study during the period of 2017 to 2030 because that's what
most of the data was available publicly. So we scout through internet and base our analysis on certain facts like geographical location, gender, kind of treatments preferred in different countries, various socioeconomical factors, and finally, what are the market drivers and barriers in the disease. So if you can see that there are year-on-year increase in the total market size for the RA. And mostly it comes from the hospital pharmacy. Retail pharmacy is very low and drug stores are even further low. So and it's increasing. Year-on-year it's increasing, and as Divya mentioned, a major drawback for us is the patent is expiring on 2028, and our drug is still in phase 2 trial, and it's severely delayed. We calculated our time. Our projected time was to complete everything was in 19 years, which Nigel will talk more about. But so the trial approval is not that promising, but the market for RA is very promising. So we can see a projected 64.5 billion in 2027, and it depends, and also it depends on various kind of treatment options available for the RA. So you see, RA is not curable completely. So you can only do the pain management or stop the progression of the disease. So there are various treatment options, right? So there are like painkillers, that is like the initial level of pain management, and then there are steroids, and then there are DMARDs, which are basically your disease modifying agents, and then there are like JK inhibitors. So there are different options available there. Our drug, which we are specifically talking about, is falls in your. You want to say something? Oh, okay. So it's in DMARD category. It's an anti-rheumatic. So we base our study on that category. So based on our total medical cost for RA utilizing these kind of treatment, and we took like 75% confidence interval, is $12,509 yearly. And then for specifically for DMARDs, it was $36,053 yearly. Sorry. So what are the major drivers for the RA specific drugs? So as I mentioned before, there's a huge population, and there is almost 1.68 million people are suffering from RA in US alone. And the data is different from CDC. This is from WHO. If we trust CDC, it's even 68 million. So the numbers are very contrasting. I just wanted to go in the lower end of it. And in world is 14 million. So you can see there are a lot of people suffering from RA, but of course they are going for different treatment methods. They are at different stage of the disease. So we have the first of the market driver is development in the prevalence of RA, and then expansion in the geriatric population. People are getting old because of the a lot of lifespan is increasing. So old population is also increasing. That disease is very prevalent in there. And then there's a rich emerging pipeline, which I'll just talk about in later for the RA drugs. And then what are the market barriers as well? There are certain market barriers as well. So these drugs, few of the advanced stage treatment options are very expensive. So that is like that post kind of inhibition to go for those kind of treatments, especially in the low cost, these developing countries where not many people can afford that kind of treatment. But they are like a huge population, and there could be a huge market opportunity, but we cannot penetrate there easily because of so they are still depending on the lower side of the medication, like painkiller and everything. A lot of people are not even aware of in those kind of strategies. And then there's a low drug adherence, and also there's a rheumatoid arthritis heterogeneity, because this RA have different variations. So that is also posing a lot of market barrier, because not one solution fits all. So that is also one factor there. Now, I talked about competitive drugs. So there's a lot of drugs that are in pipeline, and they all have their own some blockbuster drug capabilities when they come out. In fact, two of them are, so Decibel is definitely we're talking about, but there is another drug which is very hard to pronounce. It's also for Pfizer, and it's in phase 3, which is more promising. It just got into phase 3, which is more promising. For the existing drug that you guys talk about, that Humana is doing amazing, and it has a 20.7 billion market annual sale. So we have a very huge competition there, because already there are very prevalent drugs excelling the market in RA. We talk about the portfolio analysis. So we went very conservative with the numbers. So this is our total. So this is our 2029 projections. So this is 69 billion is our total world. We are projecting that they will have RA. So this would be a dollar amount for the entire world. We scaled it up to 30 billion for our achievable market, and the one that we are targeting is that is in the worst case scenario is 500 million. Because like I told you about, we would not have much time left when if we take like best scenario 2028, 2027, if we pass clinical trial, it would be just 1 year before it all starts falling down. So it has, so what we are projecting for our first year or first 2 years is like $500 million. So our valuation in best case scenario is $7 to $20 million a year. Our worst case scenario is $500 million to $2 billion. Humana is, I told, it's already selling, and so not much scope it seems from these numbers because of the patent situation and the phase trial extending. So, and these are few of the drugs that are already doing very well in the market, and these are like the dosage and the pricing and the annual pricing of the drugs, and what is the strength. So I will not go into each details in that. It was just to give you like a landscape of what we are dealing with in terms of our decade. So for cost and schedule estimation, I'll hand it over to Nigel.
Thanks, Soumya. So as Soumya put it, right, so the market looks bleak, but we still try to continue with the project assessment. So we did a cost and schedule assessment, and we used the standard DD09 document to see what kind of projection we have, and then we took the standard preclinical trials to be at 430 million, and phase 1 and phase 2 we plugged them. Currently we are on phase 2. So that's the range of 20 to 121 million, and we are projecting phase 3 of 40 million. So these numbers are coming from the document. We are using different parameters specific to RA. So that gives us, these are the costs. And similarly, those same parameters, when we apply for RA, we are getting a development time of around 9.7 years. So that's the estimation we have in place. Then we did kind of market study and try to understand what kind of pricing we can pursue for this product, and it was around $1,150 per unit. And as Soumya mentioned, we are kind of going in a conservative way. So we took the amount of patients we are targeting to reach on a yearly basis. So that's the range, and finally we have the project revenue. So just multiply them and get it 5 to 7. So that's a project revenue we're expecting. So going back to risk, which is kind of something that we are dealing with this project, kind of try to map it based on like what kind of severity. So the top one, which everyone has across the team, is rejection. So that's the highest one. The next one is basically for us because it's a 20-year patent and it's going to expire in 2028. As I'll show it later in the Gantt chart, and kind of coincides when we are actually going to launch. So that's pretty interesting. And then so that's kind of having a ripple effect on other factors. So basically the profit is going to be lesser because we have less time on market exclusivity. Also, there is actually a saturation in the market because we want to introduce a product which is drug which is already kind of, you have multiple variations of that product. So, and finally, kind of consider that, but One of the reasons why the phase 2 is really delaying is because the scope of this drug was ulcerative colitis actually in phase 1, and then they switched to a different disease, that is rheumatoid arthritis, and that's kind of like the goal with which we started with the drug and where we are actually now pursuing a kind of different. So we are still considering that as a risk, like whether that may create issues for us when we are going to FDA, like phase 1 and phase 2 having different disease treatment. So it's kind of there on the risk chart. This is a project schedule similar to what is projected. Sorry for the it's a little layout, but basically here's where we are right now. In phase 2, we are kind of anticipating a completion. It's been going on for almost 9 years, and then we are anticipating a commencement of phase 3 in at the end of this year or early next year. And this is 2027 is when we are considering FDA approval. So this is where the patent actually expires in 2028. So just get a generic R&D calculation for the product. So we made a lot of assumptions, but basically we already had the preclinical cost and some cost. We did a fully loaded cost between both the direct expenses and overhead expenses. We just took the numbers from the D09. We took a standard 2 million expense for the FDA approval span across 2 years. And finally, for the market, most of the teams had a lifespan of 20 years, but we kind of ending at 2028. We still had a negative RNPV, but we tried to drag it for 2 more years to see if there is any positive outcome. Unfortunately, no. We are still landing on a negative RNPV of -184 of 184 million. So that kind of analysis helps us to gauge, like we are kind of pursuing a process. We are pursuing that this product probably is not the right fit for the market, but for next details we are back to explain the rest of the presentation.
Thank you, Nigel. From the values for our NPV and NPV values, we came up with a decision tree development, and considering the probabilities of success and failures from the DD09 document, we considered the probabilities from transition based from phase 1 to phase 2 and then successively to FDA approval period. As learned from the previous presentations, we should have considered probability of ahead of FDA approval. The next one is recommendation for a no-go or a go opportunity. As a team, considering the volatility of the market, we decided to go with a no-go market decision. From the all reasons, we came up with 3 strong reasons to not go with the project is because of its patent expiration in the year of 2028 and its expected launch in the year of 2027. So there's no monopoly that has been created by the drug, and considering all the factors and competition, a heavy competition, it's a huge risk for Pfizer to go with it. Having negative NPV and RNPV again proves to be evident that we should not go with the project, and it can be risky for the investment and stakeholders. The last one is, as we mentioned, it was not previously and initially started with one kind of a drug variant. It was for different, and then for phase 2 it went down to RA. And right now we can see another drug, ritlecitinib, which is also having a potential and a better place and positioning in the market, and it can have a positive approach to it. So we came up with exit strategies, like what Pfizer can do and what we can recommend. The first one is exploring other geographical matters. The pros will be simpler approval process. We agree that there are some European markets and other markets which will be difficult to penetrate into. but considering the current scenario in the US, it is quite risky to launch it over here. Then the next one is selling the research and development to the other companies. So it will be a complete risk mitigation, and it will be an upfront and fixed return. The next one is licensing the development, which I personally feel is a good point to do, which also will mitigate the risk. And another factor is working on the patentability, variations of patentability. So they already have a current patent, they can work and explore various areas into it, wherein they can patent the mechanisms of the process maybe, or even the new variations or molecules or a combination of development process that they're using currently. So that can be explored more, and they can keep their research, their study to themselves and have the hold on to it and regarding the other markets and be a competitive advantage, have a competitive advantage. That's all. Thank you, folks.
Thank you. Okay, thank you for trying to compress the time because we are running low on time. Any questions or comments for this team? Very courageous to stand up with a negative NPV, and I applaud you for that. And recognizing that there are some exit strategies, so you're trying to, in essence, salvage your investment, right? And basically maximize its long-term return, which with those exit strategies, I think the licensing option did make a lot of sense. With the heterogeneity, I'm kind of concerned, how would you even do a proper, clinical trial? And how do you target which flavor or which type of RA you're actually, focused on? So that would be, one of the risks, I guess, in terms of both the testing and the development. So
We are actually testing the same Decavil in the phase 2 for a different disease as well, Pfizer.
okay,
So,
perfect.
yeah.
So there might be another opportunity that you did not evaluate here, right?
We added like but not like in the very clear sense, but we added like possibility of looking in different drugs.
But your revenue doesn't show anything.
No.
Got it. Okay, thank you very much. Nice job. I've had a request from team 1 that they go before team 2. Is that gonna be all right? Because team 1 has a time constraint. Is that gonna be okay? Team 1, if you want to get up here quickly. I know I always tell teams to keep it to 10 minutes, and I've yet to see a team do it. So maybe we'll achieve it on these last 2 teams, right? You'll notice this last team, when they were looking at exit strategies, they didn't read every pro and con. They didn't go through every, they basically focused on what is your recommendation, right? So team 2 is dealing with sickle cell. Oh, I'm sorry, this is team 1. Here you go. So this is breast cancer, right?
Yes, we're team 1 and we're dealing with ARV 471. This is a breast cancer medicine in combination with Pfizer, who has merged with Alnas. For this slide, we'll be going through 4 phases of development. First, there'll be a background overview by Riley. We'll have the timeline analysis. That will be by me. Cost analysis will be handled by Bharaka, and risk by Usman. Going ahead with background, Riley.
So to start off with a little background, in 2018, Arvinas paired with Pfizer to work on their ARV 471 drug. This drug is a selective estrogen receptor drug, aka an SERD, and it specifically treats ER plus breast cancer cases, which make up about 80% of all breast cancer cases. And the way this works is that it uses a technology called PROTACs to mark and eliminate estrogen receptors, which play a big role in the spread of breast cancer. Next slide, please. As far as market goes, it was reported in 2021 that there were around 214,000 cases of ER positive breast cancer. And according to the Global SCRD Therapeutic Market Report, this led to an estimated market of around $1 billion, which is already pretty big, but this value is expected to double to $2 billion by 2025 and again to $4 billion by 2030. Next slide, please. For competition, there is currently only one approved SCRD on the market, fulvestrant, but there are plenty of more efficient oral drugs currently in clinical trials as seen here. Most of these are ahead of ARV-471 in their current phases, but ARV-471 is the only SCRD in Pfizer's pipeline, so there isn't much internal competition. Also, because it uses PROTACs, ARV-471 is much more efficient than these other drugs, and it actually eliminates the estrogen receptors instead of just inhibiting them. For preclinical trials, Arvinas ran two simple studies, a PDX model, which is seen on the left here, and a mouse model, which is seen on the right. Both of these were just done to prove that the drug works and it's better than the current drug on the market, fulvestrant. Next slide, please.
For the clinical trials, as we can see, we have the in vitro and in vivo analysis, phase 1, that will have 83% of success rate is required, 63%. It's performed for 20 to 80 patients. Phase 2 will have 30 success rate, 30%, and few hundred patients. Again, phase 3 will have 58% success rate, and it will be performed over 100 to 1,000. Eventually, we'll be applying for application review and then the FDA results. This phase is important because normally there will be a monotherapy. That will be a drug will be tested only for its individuality and standalone applications. But for ARV-471, Pfizer has decided to test it in combination as well. So you can see there's a phase 1 monotherapy, phase 2 monotherapy, that is, it's in standalone. Phase 2 is still ongoing, while in combination, it's just phase 1. So combination drug with plavacilib, it's still in phase 1, and it will take some time before it reaches the phase 3 and eventually to FDA approval. Phase 1, when you analyze it, there were 60 participants, each being tested for different milligrams of drug dosage. The effects of it were that there was 64% mean ER degradation, that is estrogen receptor negative, and the benefit rate was 40%. The experiment lasted for 6 months. AR-471 is an oral drug, and the other competitors all were injected. So this gives it the edge, and therefore it will be passing the FDA approval sooner than the others. For the regulations, as we can see, there are multiple stages of regulatory steps that a drug needs to endure. The first step starts with clinical evaluation report. In the clinical evaluation report, you have to identify all the preclinical and clinical results has to be submitted. For defining and identifying guidelines, again, there are multiple steps. You have to ensure why your drug is better than the competitors. You have to understand the endpoints of your tumor, endpoints of the overall patient fatality rate. After confirming all the claims and working with product development, the marketing team creates a label that again goes to the approval for FDA. A new drug application has been filed, and after the approval, when it's introduced to the market, post-market surveillance will be conducted. Estimating the time, finally, we use the Bozart algorithm. The regulatory strategy has been clinical trials, delivery mode has been oral, the company has been pharma and Azon. You can see that there is 5.8 years on average that it's going to take. But given that there are 2 phases involved, monotherapy and combination, the timeline doubles and we will have 10 years. The Gantt chart, again, describes all the phases in its whole. The orange one signifies the combination, the blue one is for the monotherapy. If you see phase 3, approval happens in 26 for monotherapy, but phase 3 approval for combination happens in 29. And the product launch can be only done for monotherapy for 26, and the product launch for combination can happen in 33. Finally, the patent deadline is till 37, so Pfizer and Arvinas has good amount of time to ensure that all the phases have been completed and success of the FDA has been conducted before the actual product launch. Next up is cost analysis.
Thank you, Karishma. So I'll be talking about the cost analysis. So in order to get a background of what is the cost estimation, we took a cost phase-wise data from various platforms of BD09, Government Site, Life Science Nation, and Argonas, which is, we looked at their statements. And based on our internal analysis, we came to the conclusion that the total aggregated cost reached an amount of $550 million. So, on the basis of this standard cost, we further analyzed three further scenarios: the best case scenario, the most likely scenario, and the worst case scenario. For the best case scenario, we took the ideal situation that each phase would be expected to get over in the defined time and there will be no certain constraints. And we estimate that for this cost, it will be similar to the standard cost of $550 million moving forward. In the most likely case, since we know that for our drug development, we have different combinations of study within each phase. So we have added that cost to that particular phase and we reached an amount of $688.9 million for the most likely case. And in the worst likely case, we assume that it has not been approved by the FDA or has not passed to every single stage, due to which Argonas and Pfizer do not move forward since and they drop the project since there are no near-sighted recoveries. So next, I would like to talk about the decision tree and the risk-adjusted NPV. For the decision tree, we have conducted the analysis. For the phase 1, the input of cost was given on the basis of sum the cost of phase 1, the IND and preclinical cost of $430 million. And moving forward, at each node denoted by the blue triangle, you see that they have a probability of to reach that outcome and the potential return at that stage. So that is denoted by the blue triangles. And if you see that we have an expected total peak sales of $2 billion, and if we take that into account, you can see that at this stage, after the FDA approval, if you tend to market our drug, so we'll be having a potential return of $1.4 billion, and that is the most likely case scenario with a probability of 5.26% to reach that outcome. In the worst case scenario, we are assuming that even if we reach the phase 3 and we get rejected there because we have a high negative rate of minus $544 million and a probability of 6.2785. So that is, so if you can see that the most likely scenario, we have a return of $1.4 billion, and this graph shows you that when we move from one phase to another, so you see that there are positive return, moving from negative to positive trend. So following the same line, we would like to talk about the further decision. And for that, I would like Usman to take away.
All right, guys, I'm going to be talking about the risk analysis. Can we go to the next slide, please? So we calculated the risk associated or the success and the failure rate based off DD09 that was given to us in our class. In the left-hand side, that is the rate that was given for any drug. And then we calculated based off that the extrapolated success rate for our drug is 44.5 based on the trends, because phase 1, we're already done with phase 1, we're in phase 2. So that's phase 1 to phase 2, it's 100%. Then we expect, we took it from DD09 that it will be 61% expectancy to go from phase 2 to phase 3 and so on and so forth. So we expect the 44% to success, and then 55% as a risk factor. And then we'll talk about what risks are there that can affect the phase transitions. Go to the next slide, please. So some of the risks that we evaluated looking at, again, the documentation that was given to us by our professor, COVID-19, of course, it can cause delays in there because, you know, patients can be sick. We don't have enough patients to run the trials on it, but things are getting back to normal. So that risk falls under medium. Of course, manufacturing comes second. I think Arvinas did a really good job with partnering with Pfizer, so they can take advantage of that a partnership and get the manufacturing up and going and supply to the test facilities to run the trials smoother. Supply chain is really high right now. everything's falling behind. So I think Pfizer will come into play right there too. And of course, there's competition there, and they're in different phase 3 already. So that's of high risk too. So Urbinas has to run a tight schedule on their trials right now to catch up to the competition. And funding risk is 50-50. It falls under medium because it's split in the terms and condition between Pfizer and Urbinas that they will share the profit and the risk 50-50. So here are some of the exit strategies that we came on, looked into. First is merger and acquisition. I'm not going to read all the pros and cons, but it can create a cash flow if they Urbinas decides to go merge in after post-launch with Pfizer and give them more share, and they're not able to manage the manufacturing, and they can better use the supply chain from Pfizer, so they can go on with that idea and merge with Pfizer and give them more share of their company. Next one is IPO. Not the next slide, sorry. It can create a revenue stream, but it bumps up the liability concern, demanding stakeholders. So it's not the most viable option for Urbinas to go at this point in time or at any point. Private equity, obviously you can get that too, but Urbinas has already partnered with Pfizer as of July 2021, and they have a $600 million upfront and $350 million in equity investment, which will come in later, and then they share the profit with Pfizer 50-50. So they have gone with this option, and I think that's the most viable option for Urbinas, and they did a best fit. Position your company as a cash cow to show that there will be a revenue stream coming from their product, and they can get more investors in there, but I don't think they will be needing more investors at any time and point. Liquidate the asset, cash out investors, and keep the rest. I don't think they have a lot of assets, and they don't want to do this because it's more towards the bankruptcy, and it shows a distress signal for the business. So definitely not a viable option for Urbinas. Go to the next slide, please. So revenue potential by area, as you guys can see by this, that there's a rise in therapeutic treatments in US. As you can see, 2 capsules right there shows that it's the medium, and it will be rising through 2021 all the way till 2027. And then they have opportunity to grow more into Southeast Asia, and the therapeutic rise in the Africas is low because there's not a market penetration going on there, but that could be an opportunity for Pfizer too to tap into that market and start doing the marketing right there too. Go to the next slide, please. So we calculated the market size. We found out that the total addressable market for breast cancer as in 2020 is $20 billion and is expected to go to $38 billion with a compound annual growth rate of 8.3%, which is a huge number. And the serviceable addressable market for therapeutic is almost 17 billion right now, and it's expected to be 30.4 billion. The sum we calculated on the first year of our into the market to be 2 billion, which is 20% of 10 billion that is expected to be in 2026. So we think we have a really good chance of getting into the market and obtaining that 20% of the market by 2026. And on base of those recommendations, we highly recommend to Urbinas and Pfizer to move forward with this third and get to the development and keep a tight schedule on it to move along with the competition.
Okay, thank you. Nice job.
I would just say that I know in your risk analysis, you said that COVID was a medium risk and that things are opening up. What we have seen is that COVID actually could be an opportunity for you because so many people put off their cancer screenings during COVID that you're going to get a whole lot more people diagnosed with breast cancer, and that could accelerate your clinical trials. So just think of that.
Remove that as your opportunity now.
Yeah, exactly.
But could it restrict people from hospitals to not run trials because there's so many people and they're overbooked and there's not enough place? So maybe that's why we thought it could fall under medium.
Yeah, I mean,
depending on how the trials go. I mean, if it's an oral drug, they can take it at home, right?
Right.
Monitored, right? So you're not really seeing them in the chemo centers or anything.
Got it.
There's different layers of risk. There's the risk of getting through clinical trials and getting enough people, and getting people recruited during COVID-19. And then I think you're talking about the post market type risk. Once you're out there, the opportunity is you're going to get a bigger market.
Well, exactly. Even right now, what you're seeing is a lot more people being diagnosed with cancer, and specifically breast cancer, because women were putting off their screenings during COVID. So if you're actively recruiting clinical trials right now, you might have more patients for that clinical trial, and that might be able to accelerate your results and accelerate your launch into the market.
Thanks.
Absolutely. I think that's a competitive advantage too, that it's an oral drug, so we can send it off to the patient and they can take it and monitor somehow.
Exactly.
I have a question. Based on your revenue by region, what, if anything, well, I'm curious why the revenue is high in APAC, higher than the US, but then beyond that, I'm curious how you might change, how this might impact your regulatory strategy or like filing strategy for this drug because of those, like what trade-offs might you make based on the revenue percentage by region?
So I think by region, because ours is an RH negative drug, we've seen that there is higher concentration in the APAC and the European region in the negative blood vessels. We are starting with FDA regulations in USA because it's being developed here. After the regulations have been completed, after phase 3 has been completed, the FDA approval will change according to the APAC and the European zone. And as we have the EMEA, we have the EMEA information already, which is not put in the slides. So those information can be used to identify the FDA regulations in other parts of the world.
The implication, I think, from Zoe is that if the opportunity is greater in Asia Pacific or in Australia or one of these other markets, then you might want to consider initial market launch and your regulatory strategy focused on those markets first, right? Only because, frankly, you have to pay off the R&D, right? That's your best way to do it.
It's just, you don't always have to go US first, right? Or why maybe does everybody go US first? Maybe I should ask that.
Well, not by any kind of design in this class. I think it's more by default because they're US centered. They're thinking US, they've got FDA data in front of them, and they assume that because of the reimbursement policies here, that they're going to maximize their revenue.
Yeah, so I think that's it. So I think if you're based on epidemiology that you think there are $3 signs in Australia, but you have to think about what the access reimbursement rate at the discount price, like if you're going to charge $100K and only get $25K in Australia, right? So, but I mean, if you can get parity, right, then maybe you think about how you change your sequencing. You don't have to go US first.
The irony is in previous versions of this course, the way I designed it was not to have 6 drugs and 6 teams. It was to have 1 drug, 6 teams, 6 markets. Okay, so I said, okay, you take this 1 drug to Japan, you take this drug to Asia, you take this drug to US, Central America, Europe. So we had different teams looking at it from different market perspectives.
Professor, we thought that it might get the drug a more credibility too if it comes from FDA, and then it'll make it easier to take it to those markets, maybe, if that's how it works.
Yeah, well, that can be the case, right? That would be an analysis. What data from the FDA? Some regulatory bodies will recognize the approval by the FDA. Others are going to require their own submission. So
well, Japan's going to want their own data because of their own population.
Yeah. Yeah, so I think that's like all these trade-offs, right, that impact your project plan and really interesting things to think about. It's not just timeline through trial, but like timeline to launch post-trial.
I'm thinking next year I'll redesign the class back to the way it was, 1 drug, 6 markets, right? Okay, thanks to team. Team 2 is next and last. You guys are working on sickle cell. I apologize for the lack of time, but do the best you can.
Best for last.
Best for last.
Yeah.
So while these guys are setting up, we've got two teams with valuations above $1 billion, Team 6 and Team 1. We've got two teams that are between 60 and 150 million. We have one team with a negative NPV. Let's see what Team 2 comes up. Team 2 comes up with.
Hi, good afternoon, everyone. So today we have a final proposal for EF 07050913. So yeah, this is my team: Jorge, me, Vishal, Chaitanya, Tiffany, and Advesh. We'll quickly go through the overview. First will be the introduction by me, market size, risk competitors, and regulatory approvals by Tiffany, NPV demo, market revenue, decision tree, and risk analysis by Jorge, risk mitigation, go no go decision, exit plan strategies by Advesh, and agile drug development process by Chaitanya. So next, what is sickle cell disease? So just in a nutshell, it's because of lack of oxygen, the red blood cells try to degenerate and start to distort it, forming of shape of sickle. So it's called sickle cell disease. And so currently the mortality rate is unknown because very less population is affected by it, but it's expected life expectancy between 42 to 47 years. And yeah, so next we'll quickly go through the timeline and the analysis. We see that it is an oral release with small molecule and a new molecular entity, and we did a projected timeline of 11 years. Next. Yeah, we did a scheduling for the same using Gantt charts. And the cost analysis, we did it divided into three: a mean cost, most likely cost, and full audit cost, which will be which we will discuss it in detail later. The next are the regulatory strategies which we will take on.
Yeah, so previously we talked about some of the risks in our first presentation, and I'm not going to go over all of it, but I will talk about what we added. And one is the risk of not getting an FDA approval and patent expiration, which is 20 years. Both are highly likely, and I say that the risk of not getting an FDA approval is pretty high because of our cost analysis, which we will discuss later on. Here are some of the key market players for the sickle cell disease cures. So for regulatory approvals, this is something that we want to be attentive of from the very beginning of our research and development, and it will allow us to have a smoother approval process. Here are some of the organizations that we want to consider for our drug products. So, oh yeah.
Yeah, so I'm gonna go very, very fast over our calculations for the net present value. So what you're seeing here is the full spreadsheet model for the 20 years that is gonna take in the development and with the IP protection to get it into the market. So what we're considering is that it's gonna take 9 years for development, and afterwards it's gonna take, we're gonna have revenue for about 11 years. So we run a Monte Carlo simulation. So we consider the total affected people is gonna, we extrapolated that into the future, taking into consideration that today are 400,000 people, 100,000 in the US, and the remaining 75% mostly in Africa. So considering that, starting from year 10, we started with an adoption rate of 2%, moving on to 20% on the most likely case. And on the lower side of the scale is 10%, on the higher, like the best case scenario is 40%. With that, we are considering that doses per year are about 100. And the estimated price, we also changed it or did a simulation from $10 to 35. With that, we have the total revenue, and we assume the same cost structure that Pfizer has today and extrapolated as well into the future in this pro forma. So going down to we also assume the weighted average cost of capital of 5.35%. And we get, I'm gonna go to the summary outputs. We get a maximum net present value of $97 million and a minimum net present value of minus $36.8 million, which means that just by these calculations or these metrics, we should reject the project. The IRR on the lower end of the scale is going to be 3.41%. On the on the higher end of the scale is 9.36%. Now going to the decision tree, I mean, it's basically what other teams have showed already. But here you can see the three scenarios: the best case with a 40% market share, most likely case with 22% with market share, and the worst case with 10% of market share. I'm going to go back to the presentation.
Going to risk mitigation, we have to first make sure that we are following best practices and there's full transparency. And then we have to make sure that we are developing a conservation mindset where we are analyzing the past studies and making sure before execution we are following those research. Then we have to follow quality control where we have to make it stringent and use established practices. Then we have to make sure that we are following scientific rigor to address the transitional risk, and we should make sure that we are embracing ambiguity, because most of the drug researchers, what do? They actually publish only the findings which were useful, and there might be n number of findings which were not useful, and due to this, like the other firm which is going to do a similar research will keep on spending time on that based research. So we have to make sure that we are embracing ambiguity and involving all the failed results also in the studies. So these are the regulatory requirements which Tiffany was telling. So our major market will be Africa, because most of the African countries are affected by sickle cell disease. So 90% in 2010, a study conducted found that 90% of African countries were not able to address the regulatory requirements. So to address that, WHO and EMA and US agencies on these three established practices where they'll approve the drug for usage in African countries. So first is EMA's Article 58, which takes approximately 2.5 months. Second is the WHO drug pre-qualification, which takes 270 calendar days of WHO. And third is FDA tentative approval. It takes 3 months approximately. So these are the regulatory requirements and their timeline, which will be used for African countries. And then exit strategies. Exit strategies are nothing but first is redirected research. We can use similar compounds, similar bioassays in other drugs which are going to affect other disease or which might have other implications and other entities. Then partnerships, forming partnership with firms which are doing similar research, and then selling. Selling is one of the last options I would consider, like selling our research and trying to gauge money out of it. Then fourth is saving the research for further for a later time where sickle cell might come as a influencer disease and it might affect more number of population. So we might save the research and use it at the later phase. That's it.
So I'll just quickly go through the agile drug development process that we could incorporate into the pharma industry. Currently, as we see, it's not really dominant. Agile drug development not really dominant in the pharma industry. There are particular reasons why we could say is that there are a lot of challenges that the pharma industry faces. One could be initially could be the agile relies on self-organizing teams. And it's really difficult to self-organize teams into pharma industry because of the strong regulatory requirements and strict adherence to protocols and guidelines. And second would be the organization structure. Next, we could concentrate on these resource limitations and the market potential that agile drug development gives. That it isn't directly related to you can not directly apply it to your portfolio. So. Looking at agile drug development, how it could be incorporated into our drug, which we can see in the next slide. That is one of the first aspects could be patient or customer focus. So sickle cell disease is really a rare drug disease, and it really makes the market very small. And focusing on particular aspects and for taking into the customer specific needs, that is the unmet medical needs, as it was already also mentioned that how therapeutic needs of the customers must be taken into account. This is where Agile could help the development of this drug and speed to market. One of the major markets for this drug is African countries. But if we are considering launching it into US, there are a lot of players into US, and the market research that Agile could do in the initial phases could help us evaluate the cost of the drug in the African market, which is really high, which is not a feasible solution for the drug, which is one of the reasons this drug is a no-go for us. And identifying that would be a very first step in Agile, and this would help us to pivot early. This is what Agile helps us. One of the pillars of Agile is to identify defects early in the stages. And if we identify defects, we could pivot to different solutions for our drugs, such as thalassemia, other hemoglobin-related issues. So we would say that Agile could not be completely incorporated into pharma industries, but we could use a hybrid model for the development, in which certain aspects such as market research, unmet needs, these are some things which could be covered using Agile. And for the regular standard development process, we would propose a traditional waterfall model. And I think that's it from us. Thank you.
I think in pharma, they probably look at more risk management techniques where you do the parallel development we saw with the Pfizer vaccines for COVID. I think that's going to become more standard procedure now. But what that means is the company is taking on higher degrees of risk in exchange for the opportunity of gaining that market share faster, right? So that's going to be the trade-off, right?
Yeah, exactly. And some of you guys that have like 15-year development cycles, it would be interesting to see what it would do to your profit margin if you compress that using the same kind of techniques, and then you might actually come to a positive NPV.
And that's where portfolio analysis gets interesting, right? Everyone came in with their base case, but what if you were tasked to go back to say, reduce your development time by 40 or 50%? Well, what it costs and what do you gain? And how does that affect your NPV? As we sit here today, as we sit here with all the 6 presentations, we have 2 negative NPV cases. We have 2 cases with what I would call moderate NPV, meaning less than stellar and less than $200 million of risk-adjusted NPV, and 2 with what I would call near stellar performance in excess of $1 billion of NPV. So from that, we'd have to look at what the budgets were inside the organization. What can you afford to pursue? Would you go and just pursue the top, the top performers, the top 2? Would you bring in the middle performers? Would you then look at these exit strategies for some of these lower performers and see if that can generate more dollars to help the top performers? So this becomes a recursive analysis. This is not something that, one and done. I used to run portfolio management at Motorola. I advised at the Abbott Labs on how to do theirs. And frankly, it's a monthly process. So some people do it monthly, some people do it quarterly. But what effectively we were doing was a stage gate review right here and now. And the net result of the stage gate is which projects are passing through the gate. In other words, which ones are being funded. And finance would be sitting right up front, writing the checks effectively and authorizing those projects to proceed. Which ones are on hold or suspended, right? Which ones are killed. And we would basically categorize them into 3 categories. And some might be sent back for reformulation. Say, okay, try this approach, accelerated development. Look at a new market, change your market or regulatory strategy, right? So we would send these teams back to basically come back the next month to make, in essence, a final pitch, all right? I do want to thank all the teams. I thought you did a great job. So one round of applause for them. Thank Andrea and Tom and Olga and Zoe. I guess Zoe had to leave, but I want to thank you all for coming today. And a round of applause for these guys. On behalf of Verizon, I do encourage you to seriously consider, first of all, there's a lot of opportunities there, guys. They do sponsor, right? I checked with them. They do sponsor. They're looking for interns and full-time people. But this project is a great way for you to gauge, are you interested in this industry? And conversely, is this industry interested in you, right? I'll leave it up to you guys to make any final comments you have.
I was extremely impressed with all the presentations today. You guys did a really great job. I was speaking earlier to you. I mean, you guys are light years ahead of where I was at before I entered the healthcare industry. So you're very well positioned. We are at Horizon. We're extremely excited about partnering with you guys. I think it's an awesome opportunity. We're building our business outside the US. You don't have this opportunity in a large pharmaceutical company right now where there's really no infrastructure established at all. And what we're going to be working with you guys on is establishing technologies and platforms to help our business be successful outside the US. So I think it's really an exciting opportunity, and I'm looking forward to working with some of you on these important projects. Thank you very much for inviting us. I appreciate it.
Thank you.
Tom's board. So again, I was also very impressed with the amount of detail that I've seen in there, in all of your presentations. So thank you so much for this opportunity. I will stay here for the next, 10 minutes. So if you do want to talk to me about some of these projects, please stop by.
Sounds great. Thank you, Olga, Tom, Andrea. It's great to have you. I think there might still be some food left out. Otherwise, I will be grading your final projects over the next few days. You'll be getting some feedback on that. And from what I can tell from your midpoint, I should say your estimation submissions, you guys did great. So I don't expect anything less than great for your grades for this assignment here. So with that, have a great break, and I will see you hopefully when it's warmer outside, right? Hopefully more peaceful in Ukraine, but we'll find out, right? Take care. Yeah.
The E in this.
The A is there.
Thank you, Bob. I'm getting.
Let's go cut some beers or let's see how like a market.
Five of you.
Thanks again for the class.
What did you think, Jay?
I think the revenue slide was better. I think I made a mistake putting the slide.
Well, it had the shape of a cumulative curve, but it had the axis and the description of annual revenue. That's why I was a little bit confused. I didn't mean to derail. I certainly didn't mean to start.
Wrong shape.
Wrong shape, yeah.
The shape was wrong.
The shape and the numbers didn't line up. Well, I'll take your word for it, right?
Yeah. Because of the class, I wanted to show that after exploration it goes or it stands or it goes down. I didn't know. You said it goes down.
It's both negotiations and the slash, right? Yeah. So what did you think? How do you contrast it?
How I do
How do you compare these two? Do you like
all the negotiation last time it's something to fill the gap. People think in Europe, how I think this it up right here. This one was about project management, so it's something that I know about.
So that's something you've heard as much because you already know.
I don't, because I do project management for software projects mainly. That's one for construction.
We're all good work at pharmaceutical.
trade-off that we kind of paid for the pharmaceutical industry is that, like, at least in our team, we didn't really dive into the pharma industry. We kept it like away. We just took some numbers. We said, okay, this is the numbers that we have. Let's trust it. Let's take it as is and let's do something.
Well, I think in general, everyone had to come up with some level of understanding our markets deal makes sense.
Yeah, sure. Yeah, sure.
You know, understand.
Yeah, definitely made some kind of understanding, but we didn't like follow each number and feel like 200% sure.
Well, imagine Wall Street. Wall Street analysts, put it back, for the most part, they're looking at foreign industry.
Yeah, you're right, but they know the industry. If they want to know it even
Well, they spend more than 20%.
Yeah, they spend more than
And they spend more than 20% of the time.
Right. Sure, yeah, definitely, it makes sense. But we wanted to learn a tool. It's a tool, it's a tool, right?
You guys learned that.
Yeah, and as I said during the last class, we can take from this table of content from our report. It's 2 pages, but it's two. We can take it. The rest is not important. The table of content.
I know point.
I would argue that more comprehensive than and probably more comprehensive.
Yes, because this is
and the project.
You can't use this just if you really, it's too much. If we got 40 pages, I can't imagine like what you're gonna do with 40 pages. Nobody will read it.
Well,
anyway, you will need to present it.
How long do you think that deep dive on requirements, deep dive on schedule, and you were an all team.
Definitely use for such a deep analysis is for yourself. If you're gonna implement the project yourself. Right? I had a talk with one interesting guy. He's an Kellogg, and the talk is that they were doing one of the government they were doing a strategy for portfolio companies. Huge Russian enterprise. I asked them what their strategy looks like. Right? How many pages? They're like 50 to 200. Like the next question was, let's say, do is a report when you get it. Usually nothing.
Well, the funny largely that was based on
yeah, so many that you can't even manage.
It was almost a fantasy. A lot of numbers. Here, it's the same thing. It's internal. You've got a drug that's already in the fight. You've got $1 billion at stake. And potentially the future.
Yeah, but you can't have better numbers.
You can't have
yeah, we have another one which is 2 years old, and we have one more which is for cancer in our case. Data, 3 set of data, unrelated, it's everything brain. And you figure out like, what the hell is it?
All their data was 10 years old. Last plane they built, they hadn't built a new plane.
Boeing's data was internal, it was their own data. They knew how it generated. We don't know how the people got the data.
It's like Boeing 2 years ago. The data is 10 years old. I don't know how it was generated either, right? Because it wasn't
maybe.
So, I mean, there's always this level of any data set that wasn't produced by you.
Yeah, might be. I don't never worked in Boeing.
Well, anyways, we got you to stretch outside of your comfort zone. That was my goal, right?
Okay, thanks.
Okay, thank you. Take care.
Finally done. Thank you. Thank you.
You enjoyed it? What a driver, she's up to Verizon. Looks like they want to hire 15 people.
Yeah, a lot of questions. Totally. I think that's right.
It's 2 or 3 questions I wanted.
Sure. It was a mistake. Is this okay?